Everyone, welcome. My name is Ruben Mesa. I'm one of the hematologists here at the Mesa Cancer Center, and really excited to welcome you to this Living Beyond Cancer, A to Z. One, we're really excited to have this in person. This is a wonderful event that we have held annually, but then disrupted from the pandemic. So our most recent one in 2019, but wonderful to be here. This is a meeting that has a history that goes back many years, both here in San Antonio and in Arizona, with the concept of really coming together, both ourselves as the team here in San Antonio, as well as all of yourselves, patients, family, loved ones, to have both a morning where we cover a whole range of different topics that are shared and relevant across wherever you are in the cancer journey, and an afternoon with more kind of specific breakouts based on your disease or other areas of interest. Now, why cancer? Why are we here? Why are things like this necessary? And part of it is really the complexity of how really cancer affects us. There's so many different parts. I like to use the analogy that cancer is a thief, and it's something that we really try to battle against. You know, we all can have illness. We all eventually pass away of something in life. But why cancer is something that we have such a deep focus to try to change is because it takes from us either length of life or quality of life, or both. I, like all of you, have been touched by cancer very directly. I'm here in the middle. You could tell this is a recent photo that I had taken just recently. But my father, who there is on one side, who sadly I lost to lung cancer back in 2006, and then a grandfather who was a survivor from prostate cancer. My mother, a breast cancer survivor, much more recent photo. And again, just even my own immediate family, multiple touch points, and both individuals who were able to overcome their cancer and individuals who succumbed to their cancer. But with each of them, complex journeys that, again, many things that help to make that journey better, easier, more helpful. Now, what is cancer? Cancer is not one disease, which is one of our challenges, but really it is a theme of human illness, where, again, goes back early in time, and now with our society, it's evolved in terms of its burden. It's a disease that can affect any organ in the body. It can affect us really from birth until any age. Now, as a theme of how we're affected as humans, cancer has become a much bigger issue, in part because of how our lives have evolved. We think back in 1900, a lot of individuals passed away from infection, from flu and other difficulties. And indeed, during the pandemic, we saw a spike in this that really was a throwback to an earlier era. But as we look at even 2010 numbers, obviously not impacted, these numbers not reflecting the pandemic, we got to see that, again, a whole range of other things that can impact why an individual life will end, but cancer a much larger piece. And again, that's something we're working to change. Now, there's a strong effort to try to change this in something that is called the Cancer Moonshot, which is an effort really across the country to really make a difference, to cut the suffering from cancer, to cut the individuals whose lives are cut short from cancer, and trying to pull that together in a range of ways. Trying to change some of the aspects of cancer that truly make it such a negative impact. One, can we find it earlier? Because with most cancers, the earlier we find it, the better off we are. We know that there are rare cancers that have limited options. We know that there are inequalities in our cancer care. Individuals in which we find cancer late or have limited access to new medicines or really face barriers in terms of receiving their cancer care. The goal with the Cancer Moonshot is to decrease the rate of individuals passing away from cancer by 50% over these next 25 years, and to try to have those advances really be relevant for everyone in our society. Indeed, here at the Mesa Cancer Center, we've been integrally involved with these efforts, with key efforts that are being put forward from early detection, prevention, equity, precision medicine, meaning everyone in this audience, as I look around, is different. Different age, different background, different illnesses that you faced, and of course, all of these in a background that you're very different individuals. Your own health, fitness, the genetics that you've inherited from your family, all relevant in terms of what you face. Focus on rare and childhood cancers, supporting patients and caregivers. Again, what else does it take to help walk this journey? Sometimes it helps to have knowledge. And again, that is part of the origin of why we have an event like this today. Now, every cancer center, like the Mesa Cancer Center, really has a deep focus on its community. And our community is San Antonio in South Texas, a region roughly the size of Pennsylvania, with a population almost that of Minnesota, with almost 5 million people. Now, the Mesa Cancer Center focuses on several things. First, it focuses on you, our patients and patients in San Antonio. How can we better help your cancer journey? We focus on our community. We know in South Texas there are certain cancers that are much more common than other parts of the country, such as liver cancer. Why is that the case? How can we help make that better? We focus on the science of cancer, the biology of cancer. Only once we understand the illness can we really try to make an impact. And we focus on developing better cancer treatments. Now, the focus today is in many ways on cancer survivorship. What is cancer survivorship? There are many definitions out there. It is the process of living with, through, and beyond cancer. So being a cancer survivor is not just about, I had cancer 5 years ago. It is anywhere along the journey and the process of really helping to overcome your cancer. Another way to put it, it's everything that is distinct from the diagnosis and treatment of cancer. It's very important. One of the largest growing groups in the country, which is a sign of success, are cancer survivors. We heard just a couple weeks ago from the American Cancer Society that the rate of individuals passing away from cancer is clearly dropping. Not in all populations, not necessarily in every cancer, but it is dropping. But we are mindful as people have overcome their cancer, there are implications in their health that we need to be very mindful of. And again, our goal is to help overcome that cancer. Now, how do we help you be a cancer survivor? One, knowledge. There are many things that sometimes are complex, that you're not quite sure. And a day like today is really to be able to ask questions, both in general sessions, but also very specifically in the breakouts regarding your diseases. And we focus on both physical wellness and emotional wellness. Now, our goals today, again, are really going from also talking about new treatments and the biology of cancer to really try to empower you with really a range of tools, ideas, thoughts that might help you on your journey. Now, today you're going to hear from many members of the team involved with cancer. Indeed, trying to work against cancer is very much of a team sport. Physicians, nurses, scientists, social workers, counselors, pharmacists, in many, many different disciplines in cancer, all come together trying to help individuals overcome what they face. Now, a whole range of folks here today, and again, we'll see a whole range of different diseases that individuals are facing, and have the breakout groups to really represent that. So again, we're excited to bring our team together for you today. We continue to bring additional pieces to help grow the resources for you. We're building a new cancer hospital that'll be connected to the cancer center, connected by a bridge. That'll be a unique resource for San Antonio. And again, we focus on San Antonio. We were honored earlier this year to be able to bring in the First Lady of the United States visited our cancer center. Again, they have a strong and deep focus on South Texas and San Antonio. Again, our hope is that you come out of here with a better sense of really your cancer plan, of different parts that you can really tie to your cancer journey that will be helpful. Again, many to thank our wonderful faculty and staff who are here today to help you, our visiting colleagues, and of course many of our partners that are helping to put on this event and be present here today. So let me leave you with this thought before we break into our first talk. So we've talked a lot about what cancer can do, but let's talk about what cancer cannot do. Cancer is so limited. It cannot cripple love. It cannot shatter hope. It cannot corrode faith. It cannot eat away peace. It cannot destroy confidence. It cannot kill friendship. It cannot shut out memories. It cannot silence courage. It cannot reduce eternal life. And it cannot quench the spirit. So again, we hope that today will be a resource for you and are glad that you're here. Thank you.
Good morning, everyone. I'm glad you're all here. Thank you, Ruben, for the nice, kind introduction. And so on. So I've been tasked today to talk about advanced cancer care and research, which hopefully will lead to improved survival. Okay, so if you look at this slide, it tells you some of the cancer statistics that Ruben already kind of mentioned. We're looking at, if you look at the axis, the y-axis versus the x-axis. So in terms of the incidence of cancer, the incidence had gone up in the 1990s, and over a period of 30 years, you can see the incidence actually coming down. This is true for both men and women. In addition, the different types of cancers you see, for example, prostate, was quite prevalent in the 1990s, and that curve kind of came down a little bit to a good place, but not where we really wanted to be. And then there's a blip now for prostate cancer. And the other cancers, as you can see, are actually the incidence and prevalence are dropping, which is good to see. And this is also true with women as well. With breast cancer, for example, you can see there was a blip upwards, and now there's a plateau. So I think we are actually moving in the right direction in terms of cancer prevention, meaning new therapeutics. The pictures say a lot more than words, so that's why I put these pictures up. Now, in terms of survival rate, you can see that the survival rates have got better over the last 20 years, and the 5-year survival rates for different cancers have also got better, but we are still struggling with cancers like pancreatic cancer, lung cancer, liver cancer, really good with prostate, thyroid, and melanoma. So we have a long way to shift this curve, this swimmer's plot to the right. So there's a sense of urgency in actually making this move for other cancers as well. Now, in terms of 5-year survival based on sex and race, again, you can see that the curves are actually better. They're actually getting better. We have a little discrepancy between the races, but I think the black and the other races are catching up because we're making a big effort to include
people from all races into clinical trials, and for prevention and screening as well. Okay, now we got a bit of a blip, unfortunately, during the pandemic. Cancer care outcomes will get worse, I think, and eventually get better. We saw that because of the pandemic, resources were allocated to other programs to take care of COVID patients. And so our cancer patients actually got missed at very different places in their journey in cancer, including screening, diagnosis, and treatment. So it is predicted that cancer mortality will go up a little bit, but I hope that in the next few years that we can actually mitigate this and disrupt it and get our patients back to be screened for prevention, for treatment as well. And I saw this firsthand when I was actually in the ER on call, and there were patients coming in with full-blown cancer that could have been prevented if they got screened or if they got diagnosed earlier. And that actually all around the country, we had seen that. Okay, despite the blip, you can see for cardiovascular disease is still the #1 killer in patients, but cancer is second, and cancer will eventually take this over because cardiovascular treatments have also got better. So cancer will be the #1 killer, but we have to kind of move these millions of people who are dying with cancer, got to make it better for them. Okay, there is some good news, as Ruben actually mentioned. Cancer mortality has decreased by 32% over the last 20-30 years and getting better. The statistics that just came out of the American Cancer Society is 3.5 million fewer deaths due to cancer. So we have made progress, and the progress has been declining smoking rates and screening for high-risk smokers with CT scans, as well as good treatments for screening, prevention for colorectal, breast, prostate, and chronic leukemias, particularly chronic lymphocytic leukemia and chronic myeloid leukemias. And there have been some treatment breakthroughs, and you might have heard this: immune checkpoint therapy, targeted therapy for lung cancer and melanoma, and then now CAR T therapy, which is taking T cells and educating them and putting them back into the patient to kill the tumor. Very good, promising for lymphoma. We hope for all other diseases as well as we go forward. The World Cancer Day is February 2023, so it's an advocacy time to advocate for cancer patients, research, for better funding, better understanding. We still have a sense of urgency. A lot more research needs to be done, particularly in drug discovery and drug development. It is not just in the domain of drug companies. I think there are opportunities for academia and research institutions to also come up with new drugs and develop them, because actually it helps, because drug companies sometimes get stuck doing one thing and they don't have a broad view of drug development, drug discovery. So how do we, and then the next piece is new clinical trials. We really need to have good clinical trials, and I'll touch upon that as we go along. So if you look at this curve, on the y-axis is patient survival and time. We have been stuck with chemotherapy for the last 30-40 years. It's a blunt tool, and that's all we had. So we used it as best we could. Then came genomic targeted therapies, and I know there's someone in the audience today with metastatic lung cancer on osimertinib has done very well. Again, not everybody does well, and you can see the curve shifted to the right a little bit, but not enough. Then now we have immune checkpoint therapy, and in melanoma and lung cancer and other types of cancer, we are starting to see a plateau to the curve, meaning people are living longer and that they're not dying. And then our job now in the next 5 to 10 years is to combine these new therapies together and move that curve up where the red line is, where more people are living with a high quality of life. And that is immunotherapy plus targeted therapy. I say that, but I don't think it's simple as that, because they also come with toxicities. All right, so what kind of cancer treatments do we have? I told you we have, historically we have surgery, we still do it, radiation therapy, chemotherapy. Then we had hormonal therapy, which has been here for a long time for breast cancer and prostate cancer. And immunotherapy, drugs like Avastin, panitumumab, fairly good drugs, but not just good by themselves. And then we have targeted therapy. I just mentioned osimertinib for lung cancer. which goes after the EGF receptor, for example. Then we have stem cells and CAR therapy, and now also have oncolytic viruses, so you can get viruses, if you can, in the right way, into tumors and kill them. And then you can look at this other figure there. We have gene therapy. We can cut the bad gene out and put a new gene in that is normal. And that is an example for sickle cell disease. And also CAR therapy, I mentioned for lymphoma, but it's opening up to other tumor types as well, where you take the patient's T cells, change it, educate them, put them back into the blood, and hopefully they'll kill the tumor. Now, I want to talk a little bit about immune checkpoint therapy, because I'm sure you see on your TV sets drugs like Keytruda, Opdivo. They're going, what do these drugs actually do? So the immune system is there. The immune system is supposed to help us fight lots of different things, including cancer. And the immune system is present within the tumor, but it doesn't do its job in killing the tumor. And there's a reason for it, because there are receptors, we call them receptors, on the tumor cells and the T cells that talk to each other. And when they talk to each other, it's a frenemy. It's an enemy in disguise, right? The immune system doesn't recognize the tumor as foreign. But there are drugs now we can use to block this checkpoint, and that's why they're called the immune checkpoint inhibitors. There are also activators of the immune checkpoint as well. And these drugs basically disrupt the communication between the immune cells and the tumor cells that allows the T cells to kill this tumor. So that's how it works. Now, it works very well for some and not for others. So we still don't know a lot of the immune system and how to harness the immune system to kill these tumors. Okay, and as you can see, from 2014 to now and beyond, the drugs that are approved by the FDA going after this PD-1, which is programmed death 1, which is on the T cells, and PD-L1, which is on the tumor cells, disrupting that crosstalk. You can see number of tumor types on the y-axis, on the x-axis in time. FDA has approved multiple drugs in that, multiple indications for different tumor types. So this is an exciting area of not only research, but also promise for patients with cancer. All right, so what about the immune system? Is it really doing its job as we know it? When you give an immune checkpoint inhibitor to a patient, some patients actually progress really fast, so it's called hyperprogression. And then there are others, the orange line, where you see that the T cells are moving from the bloodstream into the tumor, and it appears on the CT scan that they're getting bigger. It's called pseudoprogression, but you may still have a good quality of life and you may still be actually doing well. So we don't stop the treatment, we keep going, and you can see that if you keep going, you have a response to therapy. Then there are those who are stable disease, nothing changes, everything is stable for months, sometimes even years. And then there are those who have a response, less than, the tumor shrinks by 30% or more, and they are living longer with their disease. And then there are others, durable complete remissions, where they have a complete remission, the tumor has gone on the scan, and it's flatlined, and so they are potentially cured. Okay? But this is not for everyone. So how can we use these drugs to make it better? So you saw a curve that in blue that shows chemotherapy. Then we have targeted therapy. There are patients who are living on targeted therapy now with advanced disease, longer time, 3, 4, 5 years before they progress due to drug resistance. And then there is the immune system, where right now for most cancers it's modest, we're getting better, and the idea is to make it even better. So that's where this research and clinical trials are going. I wanted to show you this to show you that cancer is pretty complicated. We have things called hallmarks of cancer. Essentially, if you look under the microscope, you see not just the tumor, you see the soil, which are the cells that are coming from the bloodstream entering into the tumor. We also need irrigation, blood supply. So this is just a very simplistic view of cancer, but there are these hallmarks that we understand now better, and many drug companies, many institutions and academia are working feverishly on each of these hallmarks to understand what is the driver for each person and their cancer. Okay, so there's a lot of research going on in this space, a lot of drug companies working in this space, and the question is, how do we actually combine these drugs? So think about Los Angeles, multiple highways. You block one of the highways, for example, you block apoptosis, the other highways are going to take over. So that's the problem with cancer. So we need to figure out for each patient in each cancer how we can knock out all of the highways that are making the tumor grow and kill patients. So that's the challenge, and it has been a challenge for a long time. But I think we are slowly breaking it down. All right, now drug development is also costly and timely. It is not efficient. It's because of the regulation that we have to go through. There are lots of labs in this country who have drugs on the shelf. They will never ever take it to clinical trials because they don't know how to. But drug companies are good at it. They do it, but it takes a long time. You have to test these compounds in the lab, in cells, then in mice with tumor, rats with tumor. Then you take it to dogs and monkeys sometimes. Make sure that these drugs are not toxic to those animals. And then the FDA will say, yeah, you can do the first trial now, first in human. For the first time, it's going into a human. And that has to be done by a team of investigators and nurses and a full team of investigators that actually help take these drugs from phase 1, which is only a small number of patients, to phase 2. And I'll show that in the next slide. And phase 3. And then the FDA, if they like everything that you met your endpoints, meaning duration of response, progression-free survival, overall survival, those kinds of endpoints, the FDA will approve the drug, and the drug is licensed. Okay? And then after phase 3, they go into phase 4, meaning we still are vigilant as to what these drugs can do, because we only tested a small population of patients, and we are giving it to the whole world now, and they may have side effects that we hadn't predicted. All right, just a quick update on cancer clinical trials. All the drugs that people get right now have gone through the FDA. They have to go through rigorous clinical trials. There are no exceptions. So all of the drugs you may have got went through clinical trials. There are some myths about clinical trials. They're toxic and dangerous to patients. Maybe they were 40 years ago. I don't know. It's not now anymore. It's better now, and it's much better regulated. Then there are clinical trials. Drugs are ineffective, and response rates are low. Clinical trials are for terminal patients. Not true. It affects quality of life. I don't think that's true either, because we have got better at managing all of that. And we don't give false hope. We give good hope. And that way you understand this. So we have to educate not only our team, but also the patients and the doctors out there. So you have to choose the right trial for the right patient. And we use something called molecular profiling. And I'll quickly touch upon that on the next slide. And then we can go from there. So phase 1 is basically an important investigation of a new drug. We study it in detail to get the maximum tolerated dose, and hopefully at that dose, this drug is safe and effective. It goes to phase 2. And in phase 2, and in phase 1 now, drugs have been approved, particularly in tumor types that have a particular target, for which there's a drug that blocks it and completely kills the tumor. We have those drugs that go through phase 1 and get it approved from phase 1 before even phase 2. But most of the time, drugs go through phase 2 to phase 3, and the new drug is combined with the old drug, or there's a comparison between old and new. And if the combination wins, they get it approved by the FDA. Okay? And then post-marketing, I explained to you that we still keep pharmacovigilance. And we also look at patients with liver dysfunction, kidney dysfunction, because they're excluded from clinical trials, but they can go on these drugs if they have these dysfunctions. And then at the Mesa Cancer Center, we're very lucky to actually have the Institute for Drug Development, which has been around for a while now. Our focus is our patients. We get referrals from within, from outside, from second opinions. We have our industry partners. We need to partner with the drug companies because they have the drugs, and we have to make sure we pick the right drugs. So we have to study the biology really well before we say yes. We also have teams of nurses, data managers, regulatory coordinators, PharmDs, all part of a team that actually guides the patient through the process of clinical trials. Now, I do a lot of comprehensive molecular profiling, That means we study the tumor in detail. We also do blood biopsies. As tumors grow, they break down, they release their DNA into the blood. You can capture that, but it's still the tip of the iceberg. We only get the information on DNA and RNA. I'm sure you heard of those terms. But beneath that is something called proteins, and nobody knows how all of that operates. So that's something for the future. We also have the NCI as part of our guiding light here. We have a grant that studies early phase therapeutics. It's the Texas Cancer Network, which includes MD Anderson, ourselves, UT Austin, and UT Galveston. And it's not only for clinical trials, it's also a program for educating our new generation of medical oncologists. So molecular profiling, I talked about a little bit. We can study 600 genes in the tumor, about 120 genes in the blood. What's in the blood may not be in the tumor, what's in the tumor may not be in the blood. So I studied both, so we get a better picture of what's going on in this tumor. And there are trials called basket trials and umbrella trials. So what does that mean? Very simplistically, an umbrella is basically lung cancer with different genetic changes, and we can then assign them to the different drugs. Or you can have different cancers with the same genetic mutation and treat them with the same drug. So, and combinations of this, and that's where the future is going. Actually, the future is now. We're doing all of this. All right, just to highlight one more thing, we got this grant from the American Cancer Society recently for navigation capacity building grant. And essentially what this is doing is to encourage people to have better nutrition while on a clinical trial. So it's a nutritional therapy. We're working with a company called Agilex. They have an app, which is a very advanced app actually. And what happens here is that the patient has access, wherever they live, they have access to a dietitian, and the dietitian will, and the patient gets a weighing machine. They weigh themselves once a day, and they document it. They also document their symptoms as well. So we don't see patients sometimes for 2 or 3 weeks. In those 2 or 3 weeks, bad things can happen. They end up in the ER and in the hospital. We can stop that from happening by proactively, in real time, capturing weight and other symptoms, but also encouraging them to eat the right kinds of food and maintain their weight. Because if you can maintain your weight, likely that you're going to have a better outcome. So that's the grant we got, and we hopefully can pull it off in the next 3 years, and then apply for bigger grants so that we can. And we have to build the navigation capacity of the Mesa Cancer Center. One navigator is not going to do it. We need many navigators with different tumor types to help this happen. All right. So just to give you a final word, I'm a phase 1 clinical trialist. I've been doing for over 21 years now, and I get this. Along these lines, this is what my patients tell me, this is their perspective. We who struggle to escape cancer do not obviously want to die of it. We do prefer death in the struggle to life under cancer's untenable rule. The enemy is not pain or even death, which will come in any eventuality. The enemy is cancer, and we want to defeat and destroy it. This is how I wanted to die, not a suicide, not passively, but eagerly in the struggle. And I get this constantly with most of my patients. Okay, that's it. That's my talk. Thank you very much. I need to actually acknowledge the whole village, the Mesa Cancer Center, and everybody who makes it happen for our patients, and our partners. Our partners are radiologists, pathologists, ophthalmologists, and everybody else who actually helps our cancer patients through their journey. So thank you, and I'm happy to take questions.
Good morning. How honored I am to be here. Thank you so much. And it's been an honor to work with Dr. Mesa for over a decade now, and he does so much for patients at like these amazing events. So thank you so much for being here. So take in this illustration. How many of you feel this way? It's kind of chaotic, right? You don't know what's up, what's down. You're kind of hanging on by a thread, not sure what the next turn really has ahead of you. And so I feel that many of you, and certainly many of my patients, feel like this in the system. And so I'd like to think that integrative oncology puts you back in the driver's seat. It gives you a sense of control. What are things that you can do to really drive your own path? So let's talk a little bit about what are our objectives to obtain this morning, and that's really what is integrative oncology. I'll take a few moments to define that. And Dr. Mesa already did a really great job, but we'll talk about the true definition that was developed by our Society of Integrative Oncology.
We'll discuss lifestyle modifications. However, we have fantastic speakers that follow me that will dive into diet, that they're going to dive into some physical activity. So I'm going to spend less time on those things and more time on care of the mind, reduction of stress, promotion of joy. And I think we overlook these things so often amidst our cancer care journey. And then finally, what are some of the complementary modalities that are evidence-based or certainly not harmful that can potentially complement your journey and your path? So I'm going to read this definition to you, and this is really a definition that was developed again by the Society of Integrative Oncology, and it's a patient-centered, evidence-informed field of cancer care. And it utilizes mind-body practices, natural products, and lifestyle modifications across all different traditions. And I think that's one of the powers of integrative oncology, is it's using the wisdom of the world, of the ages, to really inform what we can do to complement our care. And it aims to optimize health, quality of life, importantly, and clinical outcomes across the cancer care continuum. So that means before, during, and after a diagnosis. And I love this, it empowers patients, right? Again, it puts you back in that driver's seat. This is how I practice integrative oncology. And there truly is a rise of this specialty. Most academic centers at this time will offer some supportive care and integrative modalities. At the basis of all integrative oncology, however, is truly evidence-based cancer care, our NCCN guidelines, if you will. And that's really what makes it different between alternative and complementary versus integrative. There's truly a basis of this really robust scientific precision oncology care. Just above it, I like to think that it's a philosophy of care, that it's slowing down. It's thinking about what are your goals? What do you want to do to contribute to your path? It's communicating with your provider. It's taking the time to spend with them and ask questions and to goal set in a mutual fashion. Just above that is lifestyle medicine. Absolutely so important. And when I do my integrative oncology consultations, I spend probably 45 minutes of my hour and a half talking about nutrition and exercise, talking about recipes. We'll spend, again, less time on that today together. Mind-body medicine. I love spending time on this. This can be revolutionary in the way that you experience your day and your life. And there are simple tools that are time efficient that you can take, I think today, home with you to start putting these into practice. And then complementary medicine. And there's so much out there, and we could spend literally an entire week symposia talking about what are all the complementary modalities out there. And I'll give you just a little flavor today. When I see patients in clinic, we like to talk about the 4 pillars of wellness. And so what is that? That's care of the body, care of the mind, care of joy, gratitude, happiness. We lose sight of that, particularly in amidst a diagnosis of cancer. Promotion of connection, meaning, spirituality. These are the 4 pillars. And then speckled around, again, is the complementary modalities, all anchored on conventional Western medicine. So why is it so important? How many of you still have unmet symptoms, right? You're still symptomatic. We still have a long way to go to do our best to support you through your journey. And integrative modalities potentially can do that. We know that many of you are already doing these things, right? We've done survey-based analysis. About 40 to 60% of patients undergoing cancer care are already utilizing some form of complementary modality. And the scary part is that many are not disclosing that and not really pulling in the multidisciplinary team into that care plan. So there's really a safety issue as far as communication. We want to clearly affect disease outcomes and decrease cost of care. And then finally, we want to modulate inflammation. Inflammation is so key. It's a driver of cancer. Dr. Mahadevan just talked about that in the hallmarks of cancer, and I'll pull up that same slide he just shared about hallmarks. But modulating inflammation is not only important for primary prevention, potentially modulating the cancer in real time, but also secondary prevention for other cancers and symptoms. So this is from Hanahan and Weinberg, and it was 2011 when they last updated this. And this, again, is the drivers of cancer. Again, Dr. Mahadevan just shared this, which really underscores how important this is in cancer care. But what I'd like to highlight, again, is tumor-promoting inflammation. And what is it that is driving inflammation? We talk about chronic infections. Maybe we can't control that, we would say. But obesity, smoking, alcohol, environmental pollutants, high-fat diets, all of these are recognized as cancer drivers and are potentially modifiable by the choices we make. So how can we quiet the inflammation, calm the storm? Again, lifestyle medicine. I think this is really the key. And I have several patients come into me and they have their bag of their supplements, and it's literally like a gallon bag. And sometimes they're shopping bags. And I say, okay, well, what are you eating? And I say, well, I just had my double frappuccino, and I had McDonald's last night. And so this is the basis. This is the easy stuff, right? You must start with the clean, healthy lifestyle medicine before adding on all of the other layers. And so I spend, again, a lot of time talking about lifestyle. And I like to look at your body as a garden, right? And in your garden, as many gardens, there's beautiful flowers, there's grass, but there's also the weeds. Cancer is the weed. We use chemotherapy, surgery, radiation to pull the weed. But we still have to tend the garden, right? You have soil, you have healthy plants. And so that's what lifestyle medicine is doing, is tending the garden, nurturing your soil. And our ancient Greek philosopher and medicine guru, Hippocrates, had this right back in 400 BC. And he said, let food be thy medicine and medicine be your food. And so it's so powerful. And I love this picture because it has the rainbow. And I often tell patients, eat the rainbow. Eat all the colors. All of these colors have different phytonutrients that are synergistic, that work together, that are decreasing inflammation. And I say, but that does not mean eat Skittles. Eat the rainbow of fruits and vegetables. I said I wouldn't spend time too much on diet. It's really hard for me because I love this, but I would say that Mediterranean diet is the most evidence-based diet, huge data sets, 7,000 patients, mostly extrapolated from cardiovascular disease research, but we can see those eating the highest quartiles of Mediterranean foods have a much lower incidence of cardiovascular death. We've also done meta-analysis at the same data set looking at incidence of breast cancer, for instance. And those that were eating higher quartiles of Mediterranean foods had a lower incidence of breast cancer. And so eat your Mediterranean diet, lots of extra virgin olive oil, the more the better, to be honest, but you do want to be mindful of your BMI. These are the American Institute of Cancer Research Guidelines. This is really the gospel for nutrition and cancer care. You will have these slides, you can go through them all. I would say if I were to pick two changes out of this slide. Number one, increase fruits and veggies. Number two, no sugar-sweetened beverages. I love this diet. Of course, I'm biased. I'm from the University of Arizona and a graduate of the Andrew Weil Center. But Andrew Weil Center has this anti-inflammatory diet. It's really rooted in Mediterranean. But what's really fun is that there's little tweaks here and there. And so supplemental Asian mushrooms. Asian mushrooms really modulate your immune system. They impact your natural killer cells, which impact your tumor kill factor. And so I recommend patients to eat shiitake mushrooms, maitake mushrooms. There are supplements out there. I'm a food as medicine person. I think if you can eat your food, why take it in a supplement? So eat your shiitakes, maitakes, oyster, cook them, saute them in olive oil. We're really looking at omega-3 fatty acids. You're really wanting to increase your omega-3s over the omega-6s. Lots of ways to do that. Cruciferous family, so important. So really special chemicals in your crucifers, things like broccoli, cauliflower, bok choy. These contain sulforaphane. Sulforaphane is a very powerful chemoprotectant. And we are actually studying this at the University of Arizona as a chemopreventative for head and neck cancer. So eat your broccoli, particularly if you have an estrogen-sensitive tumor, at least a cup per day. Other things, green tea. Green tea, not in supplement form, not the EGCG, but the actual green tea that you're drinking per day actually changes how your genes interact and how they interact with your tumor suppressor cells. So it's really, really powerful. So drink your green tea unsweetened. Lots of food as medicine components here. We can talk about curcumin, turmeric, garlic, grapes, resveratrol, the microbiome, but I must move on. It's really hard. I love nutrition. Physical activity, also so incredibly important. We know that it modulates inflammation. We know that it gives you more energy. There's no better medicine for cancer-related fatigue than exercise, which is kind of confusing, right? I'm too tired, I can't get out of bed, but that's your medicine. So move your body. Big, huge data sets looking at potential risk reduction, particularly in breast cancer. We have a lot of good data for that with movement. So movement is a prescription. It is literally medicine, so definitely move your body. And we'll have a lot more in the day about movement, rehabilitation, and how you can do that in a really safe, mindful way that's personalized for you. And that's the key. You got to find something that works for you, that you like doing, and to get a team and a buddy, a community around that. Okay, so we're moving from lifestyle medicine. And let's talk about the mind and stress reduction. We know that stress triggers inflammation. This is clearly evidence-based, tons of data to show that. This is a really nice review that was done a while back, but I still love it. And it's looking at animal models, human models, and it's saying, okay, what happens with a stressed animal? Oh, I have 15 minutes, I better move. Thank you for that. What happens in stress? We release cortisol, norepinephrine, epinephrine, and what happens to the tumor microenvironment? We know that cancer cells are metastasizing faster. They're moving faster. We know that they're building more blood vessels. We could actually stain that with VEGF. And that's a chemotherapeutic. If any of you have taken Avastin, you know that we block that. And so stress is promoting that vessel growth. We know that our immune cells are not migrating very fast in stress. They're kind of dampened, they're sluggish. But cancer cells, again, are not, and neither are viruses. All the bad guys are upregulated. There's a ton of research looking at meditation and cancer, and I just did this last night and looked at the pattern of kind of the pace of change in research. And you can see just last year that there's, I think, 27 trials just last year. But you can see it's really picking up. And so this is an area of interest and a hot area of research. We know that it improves pain, depression, anxiety, quality of life, weight control. That's a lot of evidence showing that. We know that it actually changes the anatomy of your brain. With as little as 5 minutes per day, you can change the anatomy of your brain through meditation. And so the wiring, typically in America in particular, in our stressful environments, is so heavily wired through our reptilian brain, our amygdala, our fight or flight responses. And so what meditation does is it takes it out of that kind of central, kind of primitive brain and rewires it to the cortex. And so the cortex is where we have the capacity for advanced emotions. It's where we have the capacity for thought, memory. And so it's amazing. And this is actually measured on MRIs. You can see that non-meditators and meditators, that there's a whole different pattern of light up on functional MRI scans. Again, this was a 10-minute intervention, but this is seen in as little as 2, but at 5 is really the sweet spot for meditation, 5 minutes per day. I'd like to give you some resources for meditation. I love Insight Timer is my favorite. I'm biased, I'm not affiliated, but I love Insight Timer. But for those that are just beginning meditation, Headspace is really nice. There's very simple meditations. Calm is fantastic. And in fact, Dr. Mesa has worked with Dr. Huberty and looked at myeloproliferative neoplasms with Calm meditation. So there's a budding kind of a research relationship with Calm and cancer care. So again, you'll have access to these slides, but many of these are free. Download them on your phone, download them on your computer, and you can experiment and just begin to think about meditation. And meditation cannot be done wrong. You know, many patients will say, I have no idea how to meditate. I think I'm doing it wrong. Well, there's no wrong way to meditate. You just have to be aware. You sit, you breathe, and be aware of your own breath, be aware of your own body, and aware of your own thoughts. And that is, folks, meditation. Here's some more resources. Mindfulness-based stress recovery is one of the best, is MBSR, best evidence-based programs that are out there. Lots of usually community resources. I'm sure here in San Antonio they have some, but there's also a lot of online resources to participate in these programs. A couple of other resources there. I love Tai Chi. I'm a Tai Chi practitioner, I'm a researcher. We're looking at bone marrow transplantation outcomes with patients doing Tai Chi. It's so much evidence for looking at depression, fatigue, anxiety, quality of life, pain, neuropathy. All of that can be improved with Tai Chi and Qigong. This is the kind of Tai Chi I practice, Tai Chi Easy. This is the book that I love. It's also talking about breath work, self-massage, but Tai Chi Easy practices in that book. And the other thing I'd like to mention is it actually modulates the immune system. We see that lots of data showing how Tai Chi is enhancing the immune system, actually enhancing anti-COVID responses, enhancing vaccination responses. And we're testing this again in the bone marrow transplant unit at University of Arizona, looking at natural killer cell function and rates of engraftment with bone marrow transplantation. So I love Tai Chi. That could be a fun experiment. Also great for balance. Joy. I spend a lot of time in this pillar, and I've kind of crafted this pillar. I feel like this is a unique pillar that I spend time on in my clinic. And I will tell you, there's no other pillar that has the potential to transform your experience day to day than the experience of joy. And I think we lose sight of it. Again, and I mentioned that, we get so wrapped up in our experience of our family's work, diagnosis, treatment, and we forget to take a step back and say, what am I doing all this for? Why are we doing this? And what is important to me? And how do I want to experience more gratitude, more love, more joy in my life? And so just having that simple intention to think about those things is very powerful. I recommend 2 practices. One is greeting the day with gratitude, or ending. I like greeting. Thinking about what are you grateful for every day, trying to expand that bubble where we all say, you know, family, my home, but try to get creative. Start looking at the little things, like I really enjoyed that cup of tea today. That was good. That was a beautiful flower. Just the small things. And what happens is as you do this practice, those things become more accessible in real time. And your happiness scores, and this has been measured through different interventions. There's an app out there called 3 Good Things you could play with. But after 10 weeks of doing this practice, happiness scores were significantly higher. Other thing is having a joy practice. So naming something joyful, like, oh, I'm gonna go for a walk today and really take in the sky. And then be incredibly present, grateful during that, and then reflect back with gratitude. And do that once a day, every day for 10 minutes. And those are the 2 practices I like to really reinforce with my patients. And it's, again, been transformational for many patients. Other pillar is connection, spirituality, nature. We kind of lump that all together. Lots of evidence showing that those that have a connection with something outside of themselves do better with chemotherapy, have less symptoms, and have better outcomes. So I recommend a practice, whatever that is for you, every day to engage in this domain, whether that's through going outside and connecting with nature, connecting with your community, or prayer and religious practice, whatever it is that resonates within you, but something that connects you to outside of yourself. I recently got interested in this concept called post-traumatic growth. And it stemmed from a few patient interactions over the years, and they're becoming more and more frequent. And I'll tell you a story. I have this 55-year-old woman who had metastatic cholangiocarcinoma, gallbladder cancer, metastatic throughout her body. She's been through 3 lines of chemotherapy. And her oncologist, her traditional oncologist, said, well, there's nothing left. And so she comes to me in integrative clinic, and I'm reading through her chart, and I'm thinking, oh my goodness, what I have to offer this poor woman. And I walk in, and I meet her, and she's beaming. She's literally beaming. Her eyes are on fire, and she has a big smile. And we start talking, and she tells me that cancer was the best thing that has ever happened to her. And those kinds of interactions are not uncommon. And I said, well, tell me more about that. And she said, well, now I have so much access to the moment. I see what's important, and I can love with my whole heart. And I would say that there's a lot that we can learn about our own perspectives after a cancer diagnosis. So I invite you to think about that. How has your perspective changed after your diagnosis? Okay, I'm running out of time. Complementary therapies. There's so many out there. Really a lot of modalities out there, and so I invite patients to kind of say, well, what is it that resonates with you, and what would you like to investigate, and what is safe? I love acupuncture. Acupuncture, almost all my patients have at least a trial of acupuncture to see if it helps with their symptoms and their outcomes. I would say about 80% experience some benefit. Lots of data now, particularly for breast cancer. This is published in a little journal called JAMA. Really, really powerful, and this is now part of some of our guidelines that those that have early stage breast cancer on aromatase inhibitor therapy actually do better with acupuncture concurrently, are able to stay on their AI and have better cancer outcomes. So acupuncture, 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 botanical medicine. We could spend another symposia on botanicals. I encourage communication. If you're going to take any supplements, tell your team, be sure it's safe. Lots of good resources out there. The MD Anderson website has a nice resource. The About Herbs app. We also have the Natural Medicines database. That requires a subscription, but it's really great because you can put your chemo in, you can put supplements in, and it will flag if there's interactions. But be very, very careful with botanical medicine. I love foodist medicine again. So I love this capsule stuffed full of food and healthy food, right? Because that's really what we should be doing, is rather than taking vitamins and supplements, fueling our body with beautiful food. If you do take supplements, these are the stamps of quality approval. Be sure yours is a high quality. There are guidelines out there, and so the Society of Integrative Oncology is really the organizing body of which is now coordinating with ASCO, the American Society of Clinical Oncology, to develop these guidelines that have been vetted, the research has been looked at, and they agree that these are safe and effective supportive care modalities. So keep your eye out for these joint guidelines. Pain ones just came out. We have some for breast cancer, and I'm on the committee to develop more and more, so they will be coming. Set 3 wellness goals today. So go ahead and take a moment and set your wellness goals. I invite you to join us at 3:30. We're doing the Integrative Oncology workshop, and it's going to be experiential. So we'll be doing some meditation. I'll do a Tai Chi demonstration, and we'll do some more kind of planning and goal setting as a group, so you can go home with some true concrete tools. The My Wellness Coach is an app that is freely available from the University of Arizona. It's utilizing motivational interviewing, developing goals, and helps to keep you on track and gives you little kind of reminders, and so you can play with that. So take home points. Discuss your plan, please, with your provider. Use this as a team kind of endeavor and be sure that you're working together and disclosing all of your integrative modalities. Eat intentionally, mindfully. Move often. Breathe deeply and intentionally. Manage your stress as best you can. And please foster joy and gratitude. Here's another book list that you can have in the slide set. I work with Dr. Donald Abrams, who's literally the author of Integrative Oncology. He works on our education program and platform. So he's curated this list, and it's a really great resource of all of the different books and resources out there in Integrative Oncology. And so with that, I will close. And again, I am just so honored and grateful to be part of your day today, and I wish you all the very best. Thank you.
All right. Well, good morning, everybody. It's a pleasure to be here back in San Antonio. I've only been gone for like 3 weeks, but I miss it so much already. As Dr. Mesa said, I just left the university to go work at our sister campus in Galveston at the University of Texas Medical Branch. But this is where I was born and raised as an academic researcher and an exercise oncology researcher more specifically. Thank you, Dr. Mesa, for the opportunity. Dr. Gowin, Dr. Mahadevan did such a great job in kind of setting the stage for my portion of the talk. And that's going to focus on the power of nutrition and activity. And so, eat well, exercise, that's it. I'm done, right? That's a really easy talk to give, right? Because we all know that if we eat well, we feel good. If we exercise, we feel good. But what I'm going to express to you today is the why, right? And the how. Right? We know that is good for the body. We know eating well is good for the body. We know exercising is good for the body, right? Muscles, brain, lungs, bones, everything from head to toe. But what we often miss the big picture on is the how and the why, right? Like what's going on in the body, right, in response to a good diet and in response to exercise that's actually providing the benefit, right? So we're going to have a little bit of an education session today for you to walk away with some tangible evidence as to why we ask you to do the things that we're asking you to do, right? And what we're talking about today, and Dr. Gowin did such a great job of presenting this information because I'm not actually going to go as in-depth as she did about the types of foods and the types of diets, but what we're talking about today is nothing novel, right? We've known this for a long time, right? We've known that what we eat has an impact on how healthy our body is, right? Garbage in, garbage out. We've all heard that before too, right? There's no better example of that than the foods that we're putting into our body, right? And it's been known since before, I think 400 BC was one of the slides I saw earlier today, that our diet is medicine, right? And there's early evidence of the relationship between the foods that we consume and the malignancies that we've all been working on in preventing and curing here at the Cancer Center. There's a direct tie, right, within the nutritional epidemiology that we've been so well accustomed to hearing about, that there's a direct link with obesity and cancer risk and cancer occurrence, right? And so we know that having a healthy weight is very, very important, not only for primary prevention, but also as a survivor, right? We know that having a higher BMI, having higher body fat percentages is going to increase risk, right, for our chance to either have a more aggressive tumor or the chance of that tumor coming back, so recurrence, right? So we need to do what we can to alleviate this opportunity for the cancer itself to metastasize or progress by correcting the adiposity or correcting the body fat percentages that we have. And we're going to talk about that in a little bit. So how can we do that, right? It's about balance, right? I'm not telling you to go out and just completely scrape or scratch what you're eating right now, right? It's about the balance. It's about balancing what you eat with how active you are, right? If there was a scale here, not like a weigh scale, but just one of those balance scales, right? We would look at caloric intake and caloric expenditure as the two ends of that scale, right? Our job, right, is to burn just as many calories as we're putting in, right? That provides balance. When the scale tips to more caloric intake than caloric expenditure, that's when we start getting increases in body mass, increases in adiposity, right? And then if we start increasing how much energy we're expending, so our caloric expenditure, that's when we start seeing a shift, right? We start losing weight, right? We start getting a decrease in body fat percentages. So we need to eat more healthy, right? We need to be more concerned with how many calories we're taking in, what types of calories are we taking in, right? There's a such thing as a good calorie and a bad calorie, right? So eat the rainbow, but not the Skittles, right? And so we need to be aware of what we're doing to balance the scale of energy in versus energy out. Because we need to look at food as medicine. We need to look at food as energy, right? Because that's really what drives our body to do what we got to do, right? We get nutrition, we get energy from the foods that we consume, hence we're able to have a more active, healthy lifestyle. So we're going to talk a little bit about diet, right? And Dr. Gowin presented to you the Mediterranean diet, right? Looking at the pictures here, you can definitely see what side of the screen is a more healthy diet and what side of the screen is not such a healthy diet, right? And I'm not going to ask you to point to what the American diet looks like. I think we could all understand what the American diet looks like. But what I want you to know is that there's an increased risk for mortality, right, with the Western diet, right? With the more Mediterranean diet, right, we see more colors, right? We see more natural fruits. In the American side, we see more processed foods, right? We see more bulk development of nutritional products, right? And so while the standard American diet may be easy, it might be convenient, right? There's not a lot of variety in what we're eating, right? So the meal itself may be called a happy meal, right? But it's actually making your body very, very sad, right? So the Western diet itself is actually putting us behind the curve when it comes to how we're able to prevent the onset and recurrence of cancer, right? So we got to do what we can to minimize this risk by eating healthy, right? By focusing on the left-hand side of the screen, eating more natural foods, eating more colorful foods, because they ultimately will have more nutritional value. So let's talk about the why that's so important though, right? When we think about the standard American diet, we're thinking about high-fat foods, right? High-fat, high-carb, high proteins, and there's a whole area of research that's really focused on protein intake in cancer, but we're not going to go into that, right? We're going to focus more on the amount of fats that we're consuming, right? So if we think about the fats that we consume in our diet, considering the standard American diet is a high-fat diet, let's talk about what's going on within the body, particularly for our audience today when it comes to cancer onset and cancer progression, right? So the thing with a high-fat diet, right, either fatty acids that are consumed through the food itself, or fatty acids that are actually developed in the body as far as what we call de novo fatty acid synthesis. Our body actually develops these fatty acids. Is actually promoting cell growth and cell proliferation within the tumor itself, right? So the fatty acid actually giving fuel to the tumor, right? By cutting down the fatty acid intake, having this balance of omega-3 and omega-6 fatty acids, omega-6 being the better acids that we think about. By having this balance, right, we're taking the fuel away from the tumor, right? Therefore, if we take the fuel away from the tumor, it can't grow the way it wants to grow, right? And so high concentrations of high intake of fatty acids is going to promote cell growth and cell proliferation, right? So the progression of the tumor itself. It stresses the body. This oxidative stress, right? It stresses the body. It promotes inflammation. And we'll talk a little bit more about inflammation as I talk about the roles of exercise. But this is just a different pictorial description of what Dr. Gowin presented earlier about the recommendations from the American Institute of Cancer Research, which is also modeled after what the recommendations are from the World Cancer Research Fund as well. And this is also what the American Cancer Society directs as far as a nice, healthy, active lifestyle and a lifestyle that's rich in vigor, in energy, and decreasing these occurrences of these toxicities that occur with cancer. So first and foremost, the things that we're going to focus on in our talk today, we kind of touched on the nutritional aspect of it, so eating a colorful plate rather than a bland colored plate, but we're going to talk a little bit more about the physical activity component of what we're doing now. So we talked about the nutrition very, very briefly, right? We talked about the way fatty acids can promote tumor growth, right? If we take that fatty acid fuel away from the tumor, we're going to ultimately take away the fuel that the tumor uses to grow, right, and to progress and to metastasize. So our job is to take that fuel away, right, by having a better nutritional plate, right? The other way we could correct a lot of these mistakes that we make with our diet is by having an active lifestyle, right? If we're more physically active, we're going to be able to kind of not correct the errors that we make in our diet 100%, but we'll be able to kind of correct at least maybe 20 to 40% of what the mistakes we make with our food, right? So we want that balance of the energy that we consume with the energy that we're actually expelling, right? So we want that scale to be balanced. And when we think about physical activity and exercise within the cancer continuum, we see benefits in every single facet of the cancer continuum itself, right? So let's kind of set the stage for some of the talks, some of the things that we're going to talk about moving forward. So when we think about exercise and physical activity early on, we look at exercise and physical activity in the preventative state, right? Preventing the onset of tumor recurrence. When we think about physical activity after the onset of cancer, we think about it as an adjuvant intervention, right? We're trying to do what we can through physical activity and exercise to prevent the tumor from growing, help reduce some of the toxicities that occur with chemotherapy, radiation therapy, hormone therapy, these hallmark treatments that was talked about earlier this morning. And then once we've seen the tumor regress, right, we look at exercise as a preventative aspect for secondary recurrence or even tertiary recurrence after that as well, right? So we could see the benefit of exercise along the cancer continuum as we look at it here. But let's talk about cancer prevention and the role of exercise. There's a lot of evidence out there that exercise is medicine and exercise is preventative for many cancers that are presented to you here on this slide, right? There's a lot of epidemiological data that shows that. But the question now is how much exercise is enough exercise, right? We know that, again, exercise is good for the body. We know it is preventative for many of these cancers that you all are surviving from in the audience today. But let's talk about how much exercise is enough exercise and what types of exercise are going to be beneficial. So the American College of Sports Medicine, the American Institute for Cancer Research, the American Cancer Society, the World Cancer Research Fund International have their physical activity guidelines, right? So when we think about what the recommended physical activity guidelines are for cancer prevention, they're listed here, right? 30 minutes a day of basic physical activity is what's going to be beneficial to your body in preventing the onset and progression of cancer, right? Not only just cancer, but a lot of other conditions as well, heart disease, right? Obesity, osteoporosis, diabetes, right? This 30 minutes a day, 5 days a week can also help prevent the onset of dementia, memory loss, right? So if exercise was a pill, we'd all take it, right? But exercise is hard, right? It's tiring. It hurts sometimes, right? So when we think about just getting up and finding the time to do 30 minutes of exercise a day, that could be hard, right? Because we all live busy lifestyles, right? We have our day planned from the time we wake up to the time we go to sleep, right? Whether it's with our kids, with our significant others, whether it's with our grandkids, we have stuff going on all day, and we're struggling to even find the 30 minutes to carve out in our day to do this basic level of physical activity that is found to be beneficial in preventing the onset and progression of many, many types of maladies that affect us day in and day out. But I got some good news for you, right? Evidence now suggests that you don't even have to do 30 minutes of continuous activity. So even if you break this up to like 5-minute intervals throughout the day, right? You wake up and you just walk around the house for 5 minutes. You go take a 10-minute walk before or after lunch. And then when you get home from work or whatever errands you have to do, you just go out for another 5-minute, 10-minute walk after that. That all is going to add up to this minimal physical activity guideline, okay? To meeting the 30 minutes a day. So guess what we're going to do? I'm the exercise guy. And who's hungry? Right? It's been a long day. We've been sitting in these seats for the last hour and a half or so. I'm going to ask you all to just stand up with me. If you guys could just entertain me, the exercise physiologist in the room. I want you all to just stand up with me. We're going to do a little exercise snack. Things that you guys can do at home, right? Just to kind of break up the day, right? Stretch the legs, right? Stretch the arms, right? So we're all just going to get up. We know exercise is good for the body, right? Just getting up gets the blood flowing a little bit more, right? Like how many of you had feet that were falling asleep just by sitting down for too long, right? Now the blood is flowing, right? So I want you guys, if you guys have balance issues, please don't fall because I want to be invited back to this talk next year, okay? If you have to grab onto the chair in front of you, by all means, grab it. And if you just want to do some stuff in your seat, I got some modification that we can do. But let's do a couple of deep knee bends, right? Just some squats. Right? Let's get the body moving a little bit. Let's get the muscles energized. What happens when we contract these muscles is that the good proteins are being developed, right? The good proteins are being shed within the muscle. The muscle itself is an organ, right? There's a lot of evidence that's being done in the work from our group here in San Antonio and the group across the country, in fact, across the world, that shows the muscle is an endocrine organ, right? There's good proteins that are being shed or released from the muscle that's being taken up by different parts of the body that help the brain become a little bit more plastic or energetic, allows the muscles to grow stronger, allows the bones to be more healthier, right? Thank you all for doing that with me. I appreciate the encouragement. If you guys want to stand the rest of this talk, by all means, stand the rest of this talk as well. If you guys want to sit, by all means, sit. Thank you all for entertaining me, the exercise guy in the room, for doing a little bit of a exercise snack. Even doing that, right, the 2 minutes that we did that throughout the day, is going to show some sort of benefit, right? So we know in a very general sense, exercise is good for the body, it's good for the brain, good for the heart, good for the lungs, good for the bones, it's good for the prevention of cancer. But let's talk about now the how, right? Let's talk about the why. And this is a great algorithm that's been published a few years ago by Anne McTiernan, who's like one of the first to really describe the role of exercise or linking physical activity to reduction of cancer risk in our society here. And you see how all these different lines are just being pulled away from increased physical activity, right? We know that increased physical activity reduces adiposity, right? It decreases our body fat percentage. We know that physical activity reduces our sensitivity for hormones, right? It becomes a little bit a regulatory effect for our hormones and androgens and estrogens. It regulates this inflammatory response that has been talked about so much this morning as well, and we'll talk about that very, very briefly. It regulates insulin and glucose, right? So that's why it decreases risk for diabetes and all those secondary effects, right? Ultimately, if you see how this whole algorithm works together, they're all going towards the right-hand side of the screen in reducing the risk for cancer, right? Let's talk about, again, the mechanisms now of why, right? What's going on in the body? And we're going to focus our attention on inflammation, right? Inflammation is not like what we think about when we twist our ankle or twist our knee or bump something, right, where there's swelling, right? That's a different type of inflammation. We're talking about physiological inflammation, right? Things that are occurring within our body, in our physiology, right? Changes in these proteins or these cytokines that lead to biological inflammation or physiological inflammation that really is a driver for the onset and progression of cancer. These cytokines, there's good cytokines and bad cytokines, right? Just like there's good calories and bad calories, there's good cytokines and bad cytokines, right? We here in San Antonio have done some work in showing how exercise is able to modify the cytokine profile in the preventative aspect of cancer as well as the survivorship aspect of cancer as well. My group, we do some translational research, so we do a lot of animal research, but then we also see how the animal research translates to clinical trials. So we gave mice access to running wheels, right? We put running wheels in the cages of mice that have prostate cancer, right? And we wanted to see what effect exercise had within the tumor with respect to managing the good cytokines and bad cytokines, right? And we know that exercise, again, is good for the body, but let's talk about now what the mechanisms of action are within the tumor itself that provides that benefit. So what we found was 12 weeks of access to a running wheel, so equivalent to us doing 30 minutes a day of activity for 12 weeks, we found reductions in a significant number of cytokines that are associated with promoting inflammation within the tumor, right? So by exercising, we're able to decrease the concentrations of these pro-tumorigenic cytokines that promote inflammation in the body, that promote the onset and progression of the tumor itself. This is in the animal, right? But now let's talk about what's going on in the human. So we took that same project that we did in the animals, and we translated that to a clinical trial in men with prostate cancer. So what did we do with these guys? We prescribed them the 30 minutes of activity per day, the basic minimum physical activity guideline. We gave them Fitbits. We gave them Fitbits so that way we could track how active they were, right? The 30 minutes of activity a day is equivalent to our doing like 10,000 steps, right? Like everyone knows a 10,000 steps a day goal, right? You could do that 10,000 steps as a progressive activity, right? You don't have to do it all in 30 minutes. So we gave these men a flexibility in doing the 30 minutes a day in these segments, right? These exercise snacks. What we found is a downward trend of those same cytokines that we saw in the animal side in these men with prostate cancer as well. Talked about yoga. We talked about meditation. A colleague of ours here in San Antonio, Danny Hughes, is also an exercise oncology researcher as well. He did a 16-week yoga intervention where they did yoga 3 times a week. Saw the same effect, right? We talked about the mindfulness and how mindfulness reduces the stress and how stress can lead to inflammation and inflammation progresses to disease, right? Yoga is a great exercise for reducing stress, increasing flexibility, increasing strength, right? We saw the same effect in yoga in reducing these pro-tumorigenic proteins in the body as well. This is kind of redundant. This was a different study. What this study did was actually took men that were about to undergo prostatectomy to take the prostate tumor out completely. So it's to get an idea of what's going on within the clinical samples themselves. Same thing. 12 weeks of yoga saw a downward reduction in these pro-tumorigenic proteins, right? So in a general sense, we know that exercise is good for us in manipulating the proteins that are associated with inflammation and tumor progression. We also have evidence now that it changes the genetic profile of the tumor itself, right? So we talked about this translational science model, right, where it goes from animals to clinical trials. We saw some good benefits in the clinical trials, so we went back to the animal side and looked at what's going on within the tumor, and we did a full genetic sequencing of the tumor itself in response to 12 weeks of exercise. We saw a manipulation of 65 genes that are associated with the onset and progression of cancer, right? How amazing is that? Just by moving, we're changing the genetic profile of the tumor itself. And this is what our group really focuses in on in providing the role of exercise and how exercise plays a key facet as an adjuvant intervention or complementary medicine to what's being implemented in the clinic as we learned about this morning. So there's so many benefits. Now let's talk about what's going on within the microvasculature. Dr. Mahadevan talked about the highway, right? The highway system. The tumor itself has its highway system with the blood vessels that it has. Some blood vessels are really, really good. Some vessels are very, very bad. In a total sense, this microsystem within the tumor is like its own ecosystem, right? The tumor itself encapsulates itself and it has its own environment that it's using, as building itself in to promote growth and promote longevity. Our job as oncologists, as physicians, as researchers, as physiologists, as care providers, is to break up that microenvironment. So what we found was exercise is able to manipulate that microenvironment. Tumors love an environment that has no oxygen. They thrive in an environment that has no oxygen. So what would we want to do to help prevent the progression of the tumor? We want more oxygen to be delivered to the tumor, right? And the way we could do that is with exercise. What we found is with exercise, we're actually able to increase the amount of oxygen that's being delivered to the tumor, increase blood flow to the tumor, right? So that way, if we have more blood being delivered to the tumor, that means we have more oxygen being delivered to the tumor, which is the exact opposite of what the tumor wants. The tumor doesn't want blood flow to be consistent. It doesn't want a lot of oxygen. It thrives in what we call a hypoxic environment. But with exercise, we're able to increase the blood flow, as you see here on the bottom right, the right-hand side of the screen, with just simple movement, with exercise. And so hopefully I've provided some evidence as to why exercise is good for the body, why having a healthy diet is good for the body. But I know you've heard a lot from us that are doing the research, that are the providers, but I want you to hear from someone like you next as to what exercise is capable of doing in the body and how it really helps maintain a quality of life. Thank you all very much.
Thank you, Dr. Mesa. So grateful for the invitation, and I'm honored to be here along with the rest of the faculty speakers. I'm thankful for your time. Lots of great learning today. I personally learned from our speakers that went before me, lots of great education and so many things I didn't know. So I'm hoping it's helping you. We'll shift a little bit into sleep. Sleep is trickier. I have colleagues who struggle with sleep. I have friends who struggle with sleep, not to mention family members. So sleep is tricky, and we'll start slow, and I'll go over as much as I can. It's crucial to health, and along with wellness and exercise and diet, it is important to keep in mind that sleep's just a little bit harder because a lot of it may not be in our control, but there's a lot we can do to make it better. So when we look at sleep, there's a lot of features, that's just part of aging and just things we go through, the stresses of life in America in today's age is just a lot more stress-inducing, the politics and debt ceiling and all of uglier conversations in society and all of that. So there's a whole lot of reason for why the general population have sleep issues as well. And on top of that, for the cancer patient, there's a stress of going through the diagnosis and therapy. And in addition, they may have additional sleep disorders, such as insomnia is a big one, sleep apnea is another one, and a couple of others. And so the existing plethora of symptoms that a cancer patient goes through, it could exacerbate a lot of that. So we'll go into some of the disorders as much as we can. And sleep is part of one of the cancer symptom clusters. What that means is, in cancer patients especially, symptoms come together, 2 or 3 or more, and they come together and they are somehow related. So instead of looking at the symptom as an individual symptom, looking at it as a cluster, it's a different way of looking at the management in these patients. Sleep is integral to it, and it's almost always associated with fatigue, psychological distress, and it's been looked at. There's plenty of literature and data on that. So before I go into specific aspects of sleep in cancer patients, let me just jump to the slide really quick just to show you what we are looking at when we are as sleep practitioners. I do a lot of pulmonary and critical care, but I love our sleep aspect of it, and I take care of a lot of sleep patients. But the majority of what we see in cancer patients is insomnia, which is difficulty sleeping. Another big area I do want to focus on is sleep-related breathing disorders. You've heard of OSA or obstructive sleep apnea. You may have family members with obstructive sleep apnea, or you may have that as well. It's important to spend a couple of minutes on that, and then we'll just go through some of the other disorders, like the central disorders of hypersomnolence, meaning when you're too sleepy, movement disorders, and we'll briefly talk about circadian rhythm sleep-wake disorders. Insomnia is the commonest symptom reported, and there's a lot of it has to do, it's complicated. There's a whole lot of pathways that contribute to insomnia. And going back to just what I wanted to just mention about sleep symptoms in cancer, at least a third of the cancer population has some sort of sleep symptom. And depending on the type of cancer and the stage of the disease, a lot more may have sleep disturbances, and they are twice as likely as the general population to have insomnia. If you look at disease-specific involvement, lung cancer tends to carry the burden of the symptoms. I mean, it's just the nature of the disease. It affects their breathing. There's low oxygen state. So a lot of the sleep-related symptoms tend to be worse among lung cancer patients, even after therapy. But you see how prevalent insomnia is, and this is in percentage. You also see some of the others. So this is just to give you an idea. This is all comers, but then you see it broken down. I don't want to spend a lot of time on this, but this is significant in terms of percentage. Skin cancer may be less compared to the others, but a couple of other points regarding specific cancer states. Prostate cancer, for example, there's a lot of inflammation in the bladder and the urethra. It can lead to awakenings, and that's usually felt to be the cause of their sleep disturbances. Breast cancer, we see a lot of insomnia, and we're not entirely sure why that is. Insomnia along with fatigue. So most of the data we have on insomnia is in the breast cancer population. Lung cancer, we already talked about, just the nature of their disease puts them at higher risk for the sleep-related breathing disorders, and head and neck as well, for the reason that the cancer involves the anatomy. Treatment can involve the anatomy as well, and it tends to cause obstructive sleep apnea. We see that more often in the head and neck cancer population. We already went over this. So we'll spend a few minutes on insomnia. Insomnia is just having difficulty sleeping, whether that's falling asleep or staying asleep, or it's not even the quantity, it could be the quality. Patients sleep 7, 8 hours, but they don't feel like they slept at all, or they feel that the quality of the sleep was very poorly restorative. So that's insomnia, and there's many causes. There's correctable causes as well. Almost always, the right answer, the first step to treating insomnia should be cognitive behavioral therapy. So if you're talking to your practitioner or your care provider about treating insomnia, just another chemical should not be the first step to go to. I do want to emphasize that point. But in reality, we see a lot of the patients being offered sleep medications. It is fine on a case-by-case basis after you've had a discussion with your provider, but just adding another chemical is almost always never the right thing to do. So I love a lot of the points that Dr. Gowin and Dr. Patel made this morning about just non-pharmacologic ways of approaching, meditation and wellness and incorporating right diet and exercise. So all of those do help. Insomnia, like I said, is quite prevalent in cancer. When it's shorter than 3 months, we call it short-term or adjustment insomnia. For example, that could be something after a hospitalization. Pretty intense, lots of chaos, can't sleep, too many nurses, doctors coming into the rooms. That can trigger an insomnia that's sort of difficult to recover from. But if the patient recovers within 3 months, then that's adjustment insomnia. In some patients, it sticks. It just doesn't leave. And then there's a few factors that makes things difficult, and we'll look into that briefly. So there's something about the way we are made, for example, the wiring, if you will. So we all have certain traits. I mean, there's people in your own families who can sleep after a cup of caffeine, for example, or after a stressful day, they have no trouble sleeping. On the other hand, there's people, it just takes very little to throw them off, and they're unable to sleep. So there's just something about the way we are wired that helps us sleep or not. So the trait matters. Sleep gets worse with age. Babies sleep best, and as we get older, the quality of our sleep just is lower. Just a divorce, loss of a job, a bad diagnosis, so all of those can factor in. So those predispose us to difficulty sleeping, and there's other factors, as I mentioned earlier, that sort of precipitate it or make it worse. And there's a few things about the recovery path, if done wrong, can just make it harder to recover from. So, and that includes just the expectations about sleep and just the perception towards what the patient's going through. We'll go over some of these in just a little bit. As I said, not using medications is the best approach to treating insomnia. And the gold standard of therapy is cognitive behavioral insomnia. It's best done by a sleep-trained psychologist. There's providers throughout the country. It's just a matter of your institutions might already have it, and maybe your psychologist is already doing it. They're really good at doing this. Sleep hygiene we'll go over in just a bit. Medication is almost never the right answer. However, I have patients in my own family that are on medications. It's a discussion. It could be taken as a case-by-case basis. If it is to the point that it's causing the patient that much distress, it could be considered with the intention that it is for a limited period only, if possible. Antidepressants may have a role if there's a significant component of anxiety and depression. An agent that helps with sleep it can be considered, and that is not a bad option if you do have mood disorders such as significant anxiety. There's some agents that can help with that. So these are the pillars of cognitive behavioral therapy. Like I said, the psychologists are really good at doing this. We'll go over briefly some of the aspects of it. So sleep hygiene It's mostly common sense, but I have colleagues, I have nurses and doctors who, until you sit down with them and go over it, they don't realize that they were doing some of these things wrong. For example, just keeping a regular schedule, very, very important. And we're talking about circadian rhythm aspects of it, and you'll understand why that's important. Regularize sleep as much as you can. Keeping it consistent is helpful. Screens in bed, never a good idea. Don't watch TV in bed. Avoid looking at the phones, because a lot of times it's stress-provoking content that you may be looking at and things you just don't need to keep in your mind before you go to sleep. Not to mention, there's white light from the phone that trigger the wrong centers of the brain that promote wakefulness. So that's the wrong signal to be giving the brain at that point of our day when we're trying to get to sleep. So remember, there's light from the devices. It doesn't look white, but there's light from the devices that can send the wrong signals to the brain. I was just talking to one of my friends earlier about taking worries to bed. Sometimes we end up prescribing a worry time. So taking your worries to bed, again, never the right thing to do, because that just triggers off release of the wrong hormones. Dr. Gowin mentioned some of the hormones. The stress hormones, those are not the hormones you want in your body while you're trying to go to sleep. If it's possible, and if you don't think it's too silly, it may be practical to schedule a time to worry about that annoying boss that you have to go meet tomorrow, or something else at home that's bothering you. Well, if you need to sit and brood about it, what I tell my patients is that set aside a time that's not your bedtime. Don't take your worries to bed. It's easier said than done, but with a little bit of practice, you could schedule a time where you could, well, I'm just going to sit and worry about how I'm going to handle that stressful meeting tomorrow, but don't take it to bed, because it does provoke send off the wrong signals in the body. Alcohol, never good before bed. Nicotine is a stimulant. Like I said, a lot of it is common sense. Caffeine's okay, but within reason, a couple of cups and not after 3 p.m., because the metabolism of caffeine is different in different people. Some patients metabolize it in 4 hours. Some take 10 hours to metabolize it. So you know your bodies. You shouldn't be drinking 6 cups of caffeine. Like I said, 1 to 2 is useful to keep yourself awake if you have issues with that, but preferably not after 3 or 4 in the evening. Exercise, I will not spend too much time on that, but avoid gym activity within 2 hours of bedtime, because with exercise, some of those stress hormones are being elevated, and those tend to be wake promoting. Naps, there's a cultural aspect to naps. There's people from Asia, for example, or Spain. They have this nice siesta in the afternoon, and they enjoy it. If you don't have trouble sleeping, I think it's okay to take a short nap. But if there's insomnia, then we prefer that the patient doesn't nap. And we'll talk about the next feature in just a little bit, and that takes us into stimulus control and sleep restriction. A lot of these seems counterintuitive when we're talking to patients first, but actually when we break it down, a lot of it is common sense as well. Don't spend too much time in bed, and don't use the bed for eating, for example, or and consistency, we already talked about that. This is sleep restriction. Again, I have difficulty conveying this message to some of the patients initially, but then what we're trying to do is time in bed does not equal time slept. So consolidated sleep is always a better goal to have. Meaning, if you're spending 10 hours in bed, but you're only sleeping 4 hours, then the extra hours that you spent awake sent the wrong signals to your body. So what we do is we prescribe what's called a sleep restriction. It shocks patients initially, but what we're trying to do is if you're only sleeping 4 or 5 hours, well, why don't we start there, go to bed at the time that you think you'll fall asleep, and then sleep for 4 hours. Hopefully you don't have to operate heavy machinery tomorrow, and then slowly stretch it out. All right, so that's, again, it takes time, it takes patience, it takes a bit of an effort to convey the science behind that there is science behind that. It is a very valid way to treat too much time spent in bed, because that is unhealthy to sleep. Relaxation, I think Dr. Patel went over some of these, and Dr. Gowin. Yoga, spirituality, happy thoughts. I mean, think about the nice vacation that you took with your family that just brings, feelings of joy and just happy thoughts. So don't take unhappy thoughts to bed. If you're having trouble falling asleep, just take yourself to a quieter place where you focus on something that made you happy, not something that riled you up in the past. And then there's exercises, a set of exercises that you can learn to do with your provider, but there's also some educational tools on the internet as well, where different body groups of muscles are trained to relax one at a time, and that's helpful as well. Cognitive therapy a lot of it is just, trying not to look at it negatively and putting a positive spin on it. I heard one of the other patients from the audience talk about, well, how is it possible to stay positive? How, it is difficult, but having a negative frame of mind, your cortisol's going up, your adrenaline's going up, so it is definitely not helping. So what the psychologist does is just reframe some of the thought processes. Well, I'm not going to worry about the next night. Let me just worry about tonight, and ease the pressure to sleep, if you will. The medications, I just put this out there. I will not go over it in detail. I did mention the utility of agents like antidepressants if you were a candidate for it. But in general, I do have some patients on medications, don't get me wrong. It's on a case-by-case basis. In general, we should be trying non-pharmacologic measures before we resort to chemicals. And sleep practitioners are not the only ones who think that is the case. The society, the statement from the National Cancer Institute as well as the NCCN, they agree. And well, if anything, maybe it's for short-term use only and after you tried the cognitive behavioral therapy aspect. There's nothing magical about cognitive behavioral therapy. It takes time, it takes patience, and it is a bit-by-bit improvement. There's not a dramatic improvement within a week, but it does help. And so what I recommend to the patients is that just give it time, be patient, go through all of the sessions. And insomnia is tricky, but a little bit of an improvement, and we just go off of that momentum with that bit of improvement. All I wanted to mention is the several syndromes that are associated with sleepiness. Sometimes it can be a medical condition. But if you're sleepy because you didn't sleep enough, then that's treatable, especially if it was under your control. So, I have patients who sleep 5-6 hours. That's not enough. And they're sleepy, and they come into the clinic talking about their sleepiness and the fact that they fell asleep at the wheel. Well, at least 7 hours, hopefully 8 if you can. So the only way to treat this is by just allowing yourself to sleep more. And then we'll move on from there. Well, this is just one of the tools that we use to assess sleepiness. We use that frequently. You may have seen it in your clinics. Moving on to obstructive sleep apnea. So there's an association with pretty much all cardiovascular states, stroke, hypertension, diabetes, not to mention some of the more cognitive psychiatric effects when it comes to untreated sleep apnea. And the problem with sleep apnea is the neck and just the behavior of the muscles and the tissues around the neck. And we obviously don't have sleep apnea when we're awake, so it only happens during sleep. So you could have a predisposed anatomy because of a large neck or obesity. Men are higher risk, postmenopausal women are higher risk, and just something about the way we are made. I mean, I have patients with the BMI of 22 that have really narrow anatomy. That's not a problem for them when they're awake, but when they're asleep, it closes off, and you have apneas. Treatment is weight loss helps, but it's not curative, and we almost always 90% of the time, they are being prescribed CPAP or BiPAP. You have probably heard about it. And there's some other second-line options like the dental device. I can show you a picture of that. So when I'm looking at a sleep study, this is one page. This is a 30-second page. These are breaths, one breath, second breath, third breath. So these are normal-ish. And then there's no breaths after that. So that's like one event. It has to be at least 10 seconds for us to score it. But the patient's trying to breathe. This is the thorax and abdominal sensors. The patient's trying to breathe, but there's just no air passing through the airway. Sorry about that. So that's what we call as an obstructive apnea. And I've put a picture of several events back to back. And you can see why it can be so disruptive to sleep. These are breaths, no breath, and this is several seconds long. This is almost 20 seconds. So back-to-back events, these are all obstructive apneas. And you can see what's happening to the oxygen. It started off at 99, down to 73, picks up, down to 83, picks up. So this is nonstop for several patients throughout the night. And of course, different people have different severity. In some, it's mild. This is one of my patients with severe sleep apnea. You can also see what it's doing to the brain waves. This is the EEG. The sleep tests are pretty comprehensive. It gives us a lot of information. They're waking up. They're just not aware of it. Those are arousals. That's the chin that just wakes up. The patient's not aware of it. So multiple awakenings throughout the night. And this is the whole night that I've tried to pack together just to show you. These are all events back to back, lots of arousals. And here we started CPAP the same night. We call it a split night study. The events pretty much have gone away after we have taken the CPAP up to the therapeutic pressure. I mean, can you imagine the patient trying to sleep with all of these events? Quite disruptive, lots of fragmentation of sleep, lots of periods of low oxygen states. We use the word inflammation several times during the morning already, and there's a reason for why it does the damage that it is known to do. The symptoms, I won't go into a lot of details. These are some of the more dramatic symptoms, but it can be pretty nonspecific and subtle, and I think you all have access to some of these, the slides, and I'll have you all look at it at your leisure. Therapies is mostly sleep apnea. 90% of our patients, we are prescribing this. If it's mild or low, moderate, maybe we could send them to a dentist who fixes them up with a device that moves the jaw forward, so it's a bit more roomier at the back. And then, of course, there's the hypoglossal nerve stimulator. That's a surgical device. Head and neck we talked about already. It changes the anatomy there, which is why they have that. I think we talked about that already. So with sleep apnea, it's the low oxygen states, the fragmentation of sleep. I already showed you that. And just like it has that link with cardiovascular disease and stroke and hypertension, there's more emerging research indicating that untreated sleep apnea is linked to cancer. There's no concrete evidence yet, but some of the early studies, including animal models and early human studies, have indicated that, well, outcomes are worse, but there is a higher risk of cancer in untreated sleep apnea. And one of the reasons, there's several reasons. We talked about inflammation and just the stress that the sleep fragmentation and the repeated episodes of low oxygen state that the patient goes through, but it's just this inflammation that's set off and changes things at the cellular level, the oxidative stress, for example, and causes cells to behave differently. But another reason, and there's lots of exciting research in this field in the last decade, lots of groups looking at it as well, where the microbiome, the human microbiome, majority of which lives in our gut, it's trillions of bacteria, fungi, but generally healthier microbes, if you will, that work with our body. They typically don't harm our body, but could have the potential to harm if things change. So sleep apnea is felt to change has been implicated for cardiovascular disease, cancer as well as response to therapy. We won't have time to go into too much of that. That's another talk by itself. There's another kind of sleep apnea called central sleep apnea. Majority of the cancer patients don't have this unless they have heart failure, neurologic problems, abnormalities in the brain, or they are on narcotics. It's a minority of the sleep apnea. Generally, when someone's mentioning sleep apnea, it's the obstructive kind that we just talked about. But just to complete the thought process on sleep apnea, there's another kind called central sleep apnea. Treatment's a bit more trickier for that. Circadian rhythm is key to, and that's another area where the research is exploding. There's a lot of data. So the way we are supposed to, the right way to sleep is use the cues given by our biggest time giver, which is the beautiful sun, and follow the cues that it gives you. Stay awake during the day. Once dusk hits is when melatonin starts rising. So use that time to sleep. So that's the right way to do it. And again, remember we talked about regularity and consistency. But 20% of America is involved in some form of shift work. So it's not feasible to do it the way it's supposed to be done, myself included. I do shifts, right? Nurses do shifts. Law enforcement, service industry. So unfortunately, with today's society, we've just become a 24-hour society. And there's several sectors that need to stay awake to keep the world running. So shift work is a big deal. But just things that if it is not, it causes chaos if this is not followed. It disrupts the circadian rhythm, is the basis for a lot of disease states we see now. I won't go into this in detail, but we look at different disorders depending on whether our sleep schedule was earlier than the conventional schedule or later, or just broken up, or just staggering forward. This is in blind patients. So there's different disorders based on that. But with regard to the cancer population, I mean, it's at the genetic level. The disruption alters the circadian genes, and it has been implicated in pretty much most forms of cancer. So there's a lot of emphasis on regularizing the circadian rhythm, keeping things as regular as you can. The body likes structure, the body likes regularity, and anything you can do to keep that intact. There's some data on melatonin, and this is not a blanket prescription for melatonin, and that's a conversation with your doctor, but melatonin is known to have anti-cancer properties, inhibits tumor growth. And that, again, going back to the picture I showed you, that's just part of the circadian signaling. Melatonin's key there, along with the sun. Another point I wanted to make was shift work, higher prevalence of breast cancer. There's lots of data on that. We're seeing some of the other cancers as well, including colorectal. And it is because of what I showed you, because, well, the nurse who's working the night shift, she's flipped her schedule and her body doesn't like it. It alters things at the cellular level. So when I'm talking to my colleagues and the residents and fellows, I am telling them about this. It's a difficult situation because I don't see myself getting out of shift work, and my field's critical care. But just if you're able to, I would say you could get out of shift work, because the WHO and the IARC, which is the agency governing the carcinogens, is called shift work a probable carcinogen. Having said that, like I said, I myself am in shift work. So therapies when it comes to circadian rhythm is using light as best as you can, light boxes in places where it's dark all the time and there's not much sun, but it's really structuring your day. Melatonin, if indicated, again, I don't want you to go to CVS and start buying melatonin and everybody start taking melatonin. It's a conversation with your doctor, and then we make melatonin. There's a gland at the back of our head called the pineal gland that makes melatonin. So if you're making enough of it, that's all you need. but some patients might benefit from that, especially patients with circadian rhythm disruptions. Chronotherapy, that's another area where knowing the cancer and the circadian disruption helps time the cancer treatment. For example, the timing may matter to improve efficacy, maximize the efficacy, and reduce toxicity. So there's lots of data on that. There's a lot of interest in that to make chemotherapy targeted better based on the circadian timing. I think we'll finish up in just a little bit more. You might have heard about restless leg syndrome. Not every weird feeling in the leg is restless leg syndrome, and I want our fellows and residents not to jump to make the diagnosis. It has to be the discomfort that worsens when you're resting, improves when you're moving, and it has to happen in the evening when you're awake. So if you have that, and again, that's a conversation with your practitioner, you could meet criteria for restless leg syndrome. Mild to moderate symptoms, we don't treat. If you're low in iron, that's something that may benefit from being corrected, specifically the ferritin. Caffeine makes restless leg syndrome worse. Smoking does. Certain medications, antidepressants are notorious for that. Having said that, if the depression needs to be controlled, we always favor that rather than backing off that medication. So treatment is basically mostly based on the cause. This is a cousin of restless leg syndrome. For those of you in the audience that may have family members with restless legs, if they had a study, for example, in the sleep lab, the doctor is most often seeing these movements. This is a muscle sensor in the leg. Those are periodic limb movements. If it doesn't bother the patient, we don't do anything about it. So the take home here is periodic limb movement disorder. Generally does not need to be treated. It's just a finding on a study. But in some cases, and I say 1% of the cases, it might be so much movement that the spouse is feeling it and the legs are moving constantly at night and not just the tossing and turning. Those patients might benefit from therapy. This is a study that we looked at in MD Anderson where we saw the percentage of periodic limb movements was 15%, and mostly in breast and lung cancer. Some association with diabetes, so it's important to tease out neuropathy from diabetes, for example, and looking at iron is important because that can be therapeutic half the time. So if the ferritin level is low, then iron supplementation enough to get it to a higher level can eliminate the symptoms for RLS as well as take away the periodic limb movements. This is the weird side of medicine, sleep medicine. Sleepwalking, there's another one called sleep-related eating disorder, not frequently seen in the cancer population unless there's brain abnormalities or underlying psychiatric illness. Mostly reassuring them, making sure that they have a safe environment to sleep, especially for the sleep-related eating disorder. But there's a few areas for treatment, including medications if needed. So I'll wrap up with that. I think the big takeaway points is sleep is important. Aim for 7 to 8 hours of sleep if you're able. Don't give up if you have insomnia. We can work on it bit by bit, but it's also important to keep the expectations manageable because it will not improve in a couple of days or a week. It does take time. And there's a lot of emphasis on circadian rhythm, chaos, as well as sleep apnea. So you'll see more coming out in the next few years. All right? I'm happy to take questions.
Well, thank you, Dr. Mesa, for that introduction. Good morning, everyone. Happy to be here and talk with you a little bit about what I do and how we can help you guys and support you guys to really take control of your cancer journey. So we know that cancer survivors are a massive population, and through all of the advances that wonderful folks like Dr. Mesa and the team at Mays Cancer Center have been advancing cancer care, we have this growing population of cancer survivors long after their cancer treatments. And so it's estimated by 2040 there will be over 26 million cancer survivors living in the US. Huge population. Most of the American cancer PM&R programs that exist in the country are trying to meet this demand, meet this need for addressing the needs of cancer survivors, and most of these programs are predominantly outpatient. But you may be wondering, what is PM&R? What does this stand for? So most folks aren't necessarily familiar with physical medicine and rehabilitation, but that's what I do. I'm a PM&R physician, and so rehabilitation physicians or physiatrists we are experts of nerve, muscle, brain, and bone who we treat injuries and illnesses that affect how you function. So our focus anytime that we approach a patient is really to assess and determine where is the functional deficit that they may have and how can we utilize the resources that we have in the healthcare system to best address those impairments in function. And so with cancer rehabilitation, the way I like to describe it to a lot of my residents as well is the bulk of what we do in cancer rehabilitation is really just good, solid, foundational PM&R principles applied to a cancer population. So it's delivered by folks like us who are rehabilitation physicians, that we treat these physical, psychological, and cognitive impairments to decrease disability, maintain or restore function, really reduce overall symptom burden, and optimize independence and quality of life. And so we're constantly asking ourselves when we approach patients, what is the impairment that this patient has, and how is that leading to their disability or their impairment with their function? So cancer types that we treat really span the gamut. We treat folks with breast cancer who have a lot of shoulder dysfunction, lymphedema. Head and neck folks also deal with lymphedema, a lot of cervical range of motion issues in their neck, swallowing trouble, patients that have brain or spine involvement, that have neurologic deficits, tumors involving the bone, melanomas, other types of skin cancers, leukemias, lymphomas, the list really goes on. We treat really just about any cancer that you may have, any impairments that are related to the cancer itself, the cancer treatments, or even those that are not necessarily related to cancer at all. If you have just vanilla, run-of-the-mill osteoarthritis of the knees, as many of us get when we get older, those are things that we're well equipped to address as well. So things that we really focus on, as I kind of mentioned already, any complications that are related to cancer treatments, related to the chemotherapy, the radiation, any surgical, any physical dysfunction related to post-surgical impairments at any stage of survivorship. So from the time of diagnosis all the way through to long-term survivorship after you beat your cancer, or those, unfortunately, who succumb to their disease, even in the end-of-life phases, there's still things that we can do to optimize function. And so we kind of split the phases of cancer rehab into that, where we have preventive, restorative, supportive, and palliative types of interventions that we can do. And really, one of the things that we pride ourselves on is also being to differentiate for folks when they have these impairments or pains or struggles that they're dealing with. Is this something that is related to the cancer or its treatments, or is this something that's non-cancer related? One of the things that I enjoy most is when I'm working with patients is to tell them, you know, hey, this is not something that's from your cancer. There's a pretty easy fix for this. We'll get you started and going on your treatment, and we'll get you feeling better and more functional. So some examples, this is kind of an exhaustive list, and it's purposely not meant to be legible, so don't worry about that. We'll focus on a few. But we cover a lot of different things. So chemo-induced peripheral neuropathy, we know that chemotherapy can affect the nerves in various ways, and so we work on that. Radiation fibrosis syndrome, where you have decreased functional mobility or range of motion in certain joints as a result of the radiation treatments. Lymphedema is a big thing that we work with. But I really want to focus in on prehabilitation. This is an area that is gaining a lot of ground and a lot of excitement within the cancer community, and really physical activity overall is something that can be beneficial at any stage of your cancer journey that you're at. So prehabilitation or prehab, this is pre-treatment optimization, really with the idea that you have this process that you're going to go through, and we're trying to build this functional cushion, knowing that you're going to have some major chemotherapy regimen, some major surgery, something that is going to adversely impact your function. And so with the time that we have leading up to that treatment, we identify folks who are going to be in that are at high risk for having this functional impairment, and really try to work with them in a multimodal approach, stressing physical activity, nutrition, psychologic interventions for goal setting and things like that, and where applicable, smoking cessation. So the goal overall is really to reduce the anticipated treatment-related impairments, decrease length of hospital stay, decrease rates of post-operative complications, reduce the number of ER visits and hospital admissions, and achieve, in some cases, what we call RIOT, this return to intended oncologic treatment. There are certain times where patients have to have a dose reduction of their treatment for their chemotherapy, for example, as a result of side effects that they're experiencing, but some of this stuff can be prevented to a degree by engaging in a good regular physical activity program and keeping you moving and really moving through your cancer journey that way. One of the more exciting things with physical activity and exercise and folks who are being treated with cancer comes from a study that was done at MD Anderson that was kind of in the preclinical phases and starting to expand. So, and this is just really a microcosm example of how exercise can be beneficial beyond just your physical function. So there was this study that they were looking at pancreatic cancer, notoriously very difficult cancer to treat. It's very poorly vascular, there's not good blood flow there, and so it makes sense that the chemotherapy that is delivered through the bloodstream to the tumor itself, if you don't have good blood flow into the tumor, you're not going to get as well of penetration of that chemotherapy into the tumor, and it's not going to be as responsive. Well, with physical activity and exercise, we know that there are circulating growth factors that promote better blood flow, that promote formation of blood vessels. And so looking here, they tagged these endothelial cells, the cells that make up blood vessels, and you can see in this exercise group, there's really not any organized blood vessels here. However, in the exercise group, we have things that look more like blood vessels structures that are promoting blood flow into that tumor. As a result, if you're looking at this compared to the blue control where they didn't have any exercise, just normal activity, the size of these tumors are actually considerably smaller after treatment, and that's theorized to be a result of improved blood flow to that tumor and improved delivery of the chemotherapy to that tumor. And so that was in a mouse model, and fairly promisingly, similar results were shown in some patients that were treated at MD Anderson who had prehabilitation type interventions and underwent cancer treatment. And so when we're framing physical activity in that context, where we're not only necessarily preserving physical function, where we're helping people maintain their mobility and their overall independence through their cancer treatment, but now we're potentially even enhancing the effects of cancer treatment, making tumors that were potentially inoperable before or not a surgical option available, now having better response to chemotherapy and potentially achieving a cure. This is a big game changer. So physical activity really can be beneficial to you, really at any stage, but especially early on. So a prehabilitation program, a good one, and one that we're trying to build here at the Mesa Cancer Center, involves oversight by a physical medicine rehabilitation specialist like myself, a nurse who functions as the patient navigator, who's checking in with folks, seeing how they're progressing with their physical activity, monitoring closely for any musculoskeletal injuries that may occur, and treating them appropriately, with goal exercise amounts being kind of what we talked about here. These are the higher goals that were the old guidelines. I'll talk about what the newer guidelines are that have a little bit more achievable goals for folks who are really struggling with fatigue. But having the combination of aerobic exercise, resistance exercise, those two arms really come together to provide a good foundation for physical activity. Having a dietitian involved in counseling on high protein intake to help feed those muscles that we're working on during your physical activity programs. And then psychology to help with stress management, exercise planning, adherence. We all lead busy lives. You guys all have lives outside of the cancer center, and we recognize that and appreciate that. And so finding ways in which you can incorporate some more physical activity into your already busy lives and schedules so that you're still able to get benefit from the physical activity that we want you to do. So I mentioned some of the guidelines, how they've been updated. The American Cancer Society and the American College of Sports Medicine recommend at least, this is a floor, so you get bonus points if you go above and beyond, but at least 90 minutes a week of moderate intensity aerobic activity. So what does moderate intensity mean? Moderate intensity, we used what's called the SING test. So when you're walking, running, exercise bike, arm bike, elliptical, whatever your preferred method of aerobic activity is, you should be out of breath to the point where you're still able to get some words out, but not so much having not enough breath to sing a song or carry a tune. And so we're not talking about, huffing and puffing and breaking a sweat and everything. This is just nice, even, steady pace. You're still able to have like a nice chat, but you're working a little bit. You're feeling it. Resistance exercises, again, as a floor, we want at least twice a week, really focused on the big muscles of the chest and shoulders, hips and thighs. These are the muscles that are the ones that are attacked most first by the breakdown that occurs. Fighting cancer and the cancer treatments that you're subjected to puts your body in a catabolic state where it's just churning through calories. And where it starts to break down first is, unfortunately, our bodies don't break down the fat that we have first, they break down the skeletal muscle. And where it pulls from are these big muscles of the chest and shoulders, hips and thighs, our core muscles. And so we're doing resistance exercises to focus on those and help protect those muscles that we really rely on for posture, for getting up and sitting down, for getting out of a chair, getting out of bed, all of these very pragmatic physical functions that we need from a day-to-day basis. That's what's going to help protect. And so I tell folks they can start with even just sit to stand exercises at home. Anytime you sit down on the chair, you get up from the chair, you're effectively doing a squat, right? And that's a complex dynamic movement that's hitting your quads, hitting your glutes, hitting your hip flexors. So these are very, very beneficial exercises to do that you already are doing just through moving through your life. And then, as I touched on before, protein. We want to feed these muscles as we're working on them and really help promote good muscle recovery. The biggest thing that I think is not as harped on as I wish it could be is at least one of those protein loads being within an hour of completing your exercise program. That's a time frame where your muscles are most metabolically active and ready to take in that protein load to go directly towards muscle recovery. So that's one of the things I try to mention with everyone. But getting, the goal is between 1 to 2 grams per kilogram per day. So whatever your body weight breaks down to in terms of kilograms, that's your goal. So I include this slide and encourage you guys to take a snapshot of this as well. Fatigue is probably the most common symptom from cancer. It's this very almost flu-like feeling. Your body just feels achy all over. You're just constantly drained. You go to sleep, you wake up, it doesn't make a difference. How long you sleep, what your quality sleep is. It's just this constant like flu-like feeling. Just everything's just kind of gross feeling. And so it's been well established in the evidence that even though you don't feel like doing anything, the first line treatment for addressing that type of cancer-related fatigue is exercise. And so even starting slow, there's been good evidence to show even time frames as short as 8 minutes of physical activity still yield measurable benefits. So we're not asking you to do big long marathons. No one expects you to get to the 90 minutes a week on the first week. So I like to share this regimen that's kind of this gradual progression over an 8-week course to really help start getting you started. Because the last thing we want is when you're starting a new physical activity program that you go too hard too fast. And then that's very discouraging because you feel like you got hit by a truck for a few days after, you don't do anything for a couple days, and then all of the benefit you would have had from starting a regular physical activity program is kind of lost. So start slow, listen to your body, take it day by day. Stretching, this is a big pet peeve of mine. So flexibility is very, very important. So best times to stretch are right after a warm-up. So just kind of general, moving around, raising your arms overhead, going through your full range of motion for all of the joints of your body. And then immediately post-exercise, really with a focus on all of the muscles that you worked on during your physical activity program. So my rule of thumb, because most people do not stretch nearly enough, is for every 1 minute of resistance exercises that you're doing, you should be stretching those same muscles for 2 minutes, okay? Because really flexibility has such benefits from decreasing rates of injury of those muscles after exercise, helping promote muscle recovery, reducing post-exercise soreness the following day, and just promoting lean muscle tissue when you're working on this exercise program. And so other rules of thumb that I have, hold the stretch. Stretches should never be painful. You go to that max range of motion. A little bit of discomfort is okay where you feel that deep stretch, but it should never be painful. You want to hold the stretch, and the longer you hold it in that deep stretch, the more benefit you're going to derive from that stretch. Usually aim for like 20 to 30 seconds. Things to think about, because safety is always top of mind. Considerations you want to have before starting a physical activity program. Talk to your doctor if you have any cardiac issues. Make sure you get the okay from them. Any high blood pressure, diabetes, COPD or asthma. If your blood counts are very low, you want to check in with your doctor first. Any impaired balance or high risk of falls, and then of course any skeletal involvement of your bones, brain or nerve involvement or muscle involvement of your cancer. Just make sure you get the all clear from your physician. But it's important to note that these are not necessarily exclusionary things for you doing a physical activity program. All it really means is that we need to just maybe take a step back, assess everything, maybe modify your physical activity program a bit to make sure that you're performing it in a safe way. But it's been demonstrated time and again in the literature that it is safe for folks to exercise during chemotherapy, during radiation treatments, immediately after surgery. And so I really, really highly encourage you guys to be able to do that. One of the biggest things that I tell my patients when I see them in clinic and I'm talking about this stuff is the cancer journey can feel like a very prescriptive process sometimes, where you see your oncologist, you see your surgeon, you see your radiation oncologist, and it can feel like things are being done to you, right? I go here, I get my chemo, and they just kind of give that to me. For surgery, I get the surgery they tell me to do, and then I'm just kind of trying to recover. But physical activity, what you do with your diet, these are things that you have control over. And this is a very meaningful way for you guys to take control of your cancer journeys in a way that can have long-term benefits and really help benefit your cancer. So I believe in you guys. Y'all can do it. I strongly encourage you guys to, ask any questions that you have. But with that, I'll open the floor to any questions. So thank you.
This is a tremendous thrill to be here. You are my tribe. You're the kind of people I've been connected with for more than half of my life, and it's a tremendous privilege to be here. I need to acknowledge a couple of people before I go any further. Dr. Mesa is a savant. He's an administrative clinical genius, and he's been able to create one of the premier cancer delivery systems in the world right here in your area of San Antonio, Texas. So please, a warm round of applause. Without the expertise of Lori Varner, I'd be having a stroke out here. She's been able to pull this program together, and I want to thank in particular Robert from AV Tech Support. The tech people can make or break us. Now, before I go any further, I want to share with you two things that I learned coming here. Number one, Dr. Mathew made the comment that melatonin, and I didn't know much about this, has something to do with inhibiting cancer growth. So I think we need to understand if we are sleep deprived, that certainly is not going to help our cancer situation. And as Dr. Fricke mentioned, I didn't understand that if we have an advanced cancer and we're physically fit, more of the anti-cancer medicines can attack the cancer. So this is a gift that you all have given me. And I think I need to emphasize that the two specialties that every one of you needs to access, number one, the physiatrist and the physical therapist. Every one of you deserves to have a consultation with that specialty. And you also need to ask your primary care people to have access to a sleep disorder person. And I also would add a nutritionist. Dr. Fricke talked about us having about 30 grams of protein. None of us have any concept of what we're eating. So you deserve to sit down with a registered dietitian and review with you some of the key aspects of your diet. So my promise over the next hour and a half, that usually works in Minnesota, but you've been here for a long day. But over 15 or 20 minutes, I want to share with you some tips and insider tricks to go the distance, because your physicians and healthcare providers are overwhelmed. They're playing with a computer system that is draconian, and there'll be a special place in hell for the person who's designed the electronic health record. And you know where I'm coming from. That in Minnesota and in Texas, your providers are spending an extra 25 hours a month playing with the computer, an extra hour and a half a day. Rather than sitting at you and hearing your concerns, they're playing around with the computer. So let's have you just bear with me over the next 25 minutes or so. By the way, I haven't seen the sun for about 6 months, so to come down here and see it's gray, I want my money back. I was expecting... Let me share with you my email address. Please write this down, because every major advance has been triggered by a question by a patient. A generation ago, if a woman had breast cancer, she had a mutilating procedure, removing the breast, removing the chest wall muscles, and she developed a swelling of the arm. And women cried out, "This is not satisfactory." And now we have lumpectomy. We have a Band-Aid procedure over the site of the cancer, and I've seen documentaries of women nursing in the breast that had the cancer. So if you have an idea, if you're angry and frustrated with the way something is going, let us know, because you're the consumers and you deserve the best care that we can give you. Creagan.edward@mayo.edu. Okay. Now, let me share with you the book. This book is about 100,000 words, And we wrote this about 2 years ago because patients and families were dissatisfied with what they were hearing from organized medicine. And this book has been a bestseller at Amazon. And I want to stress to you, this is very important, the book is gluten-free. So if you eat it, you're not going to develop piles or hives or anything like that. And every one of you has a story that needs to be told. A story of resilience, of perseverance, of tenacity, a story of humor. Some cancer patients and recovering alcoholics are the funniest people I've ever dealt with. Now, you don't want to marry a recovering alcoholic unless they're in recovery, but otherwise, they can have a bizarre sense of humor. Okay? Now, here's a hospital corridor at the Mayo Clinic, but this could be the Mays Cancer Center. So when we go to see that healthcare provider, we are racked with anxiety. We didn't sleep. We have aches and pains. We have no concept of what we're going to be told. And it's like winding up in a foreign country. It's like me and my family dealing with insurance agents, tax people, estate workers. You know, what do we know about this? But we don't want to look stupid, so we nod our head and walk out and can't explain what the provider told us. So let's talk about what we need to do when we're in that room and the stakes are high. And right here, as I mentioned, you have the premier healthcare delivery system in the state of Texas. Now, I'm sure people in Houston might be a little bit upset about that. But right here, Houston, that's a city here, right? Okay, all right. Now, does anybody recognize this person? Okay, this is the Wizard of Oz. No, Dorothy was from Minnesota. Her name was Judith Glum. But just to backtrack about the story for a minute, let me just turn off the light for a minute. Basically, Dorothy was a happy little kid. She was in junior high, living on a farm in Kansas. And then there was a tornado, and it drops her in the middle of Oz. So Dorothy wakes up with her little dog and says, "We're not in Kansas anymore." And medicine today is not the medicine it was of our grandparents or our fathers. Medicine then was a paternal relationship. It was, not a transaction. But now it's become somewhat corporate and somewhat mechanical. Now, remember these people? I can tell your ages. I can tell when you were conceived. I won't go into the details. So the person on your left is whom? Marcus Welby. And the person on his right is Dr. Kildare. Okay. And everybody loved them. They delivered you. They transplanted your heart, you know, all that sort of stuff. But now it's a little more complicated. Now, let me share with you a story. This is part of my family. This is my best friend, my marriage partner, Peggy. We have a million marathons, and we're blessed if we marry our best friend, right? We're blessed, okay? And this is, Jack is CPA. This is Michael, who's an anesthesiologist. This is Bob, who was an owner of a dental lab. So a couple of months ago, Michael told me he was really sick. He thought he had the flu. He thought he had COVID. He was short of breath. He was bringing up phlegm, racked with fever. And he said, I was in touch with my provider, and I was given steroids, 2 antibiotics, and an antidepressant. And guess what? This was all done over the telephone. A couple of years ago, that would have been almost malpractice. So we just have to recognize it ain't the way it was. We have to accept to get the care that we want. Okay? So he had intensive treatment, which most of us a few years ago would have had him come to the office. That would have been the right thing to do, but it's not practical. So that's what's happening today, telemedicine. Right? Now, right now at Mayo Clinic, about 1/3 of our consultations are done virtually. And you and I know you need the eye contact with another human being. Otherwise, it becomes a transaction. That raised eyebrow, that grimace, that walk, all of those are crucial in making a decision about management. So telemedicine is convenient and it's easy, but when the stakes are high and failure is not an option, we have to appropriately insist on that face-to-face encounter under usual circumstances. But nothing substitutes from this. That eye-to-eye contact with someone that knows who we are, someone who's concerned about us as a human being. So when you have a serious problem and your provider wants to use telemedicine or the phone, it's probably not an ideal situation. Now, if you're ill, if there's a blizzard, if you live in Minnesota, obviously one has to be reasonable about these things. But in an ideal world, that face-to-face. Okay? So if you're in the midst of chemotherapy or radiation therapy or some other intervention, we need to understand what we are buying from that treatment. We'll come back to this in a minute, but we need to know the pros and the cons and the risks and the benefit. Now, let me tell you about this gentleman. This is my biological father. Now, I say biological because I had a stepfather. And he was a high school graduate. He never had a Social Security card, but he had $600 cars and $200 suits every couple of years. And he was a savant. And he also made his living as a jockey's agent. He represented the jockey to the trainer. So he became brilliant in predicting which jockeys would win. And what I heard from him, there's no such thing as luck and there's no such thing as a roll of the dice. The fact that we're here this morning has nothing to do with chance. There is some higher power, there is some energy, however you may define it, that brings all of us together. And you didn't simply wake up this morning, boom, let's go hear some of these people speak. There was planning, there was organization. Who's going to take care of the kids? Who's going to take care of the cat? Now, let me share with you a story. 1991, I received a phone call from a provider in Nebraska about a young gentleman. At that time, he was 18 years of age, and he had a black mole cancer over his shoulder blade. This was malignant melanoma, one of the most lethal cancers that we see. Okay. 1991, comes to Mayo Clinic. We could feel a lump under his arm, had what's called an axillary lymph node dissection. And I have the operative report here in the pathology report. This is 1991, and listen to this. 14 of 22 lymph nodes were exploding with metastatic cancer. So 14 lymph nodes were replaced with cancer, and the dark material here are cancer cells embedded into the muscles of the chest wall. So the prognosis should have been maybe a couple of months. And at this time, interferon came on the market. And I believe it was the first cancer medicine to appear on the cover of Time magazine. So we sat down with him and his family. We talked about what's involved. We said, this may prolong your life. We don't know. Serious side effects that almost everyone gets. So we mapped out where this trip was going. And he says, you know, I love you, baby, but I'm not going to take this. Thank you for telling me what I need to know. I'll come back and see you every 6 months. So here he is in 2003 with his family. And here he is, this was 2015. And now in 2023, he's alive and well. So I tell you this story because we're not prophets. We cannot predict what will happen. And everyone in this room knows someone who was given a dire prognosis, and yet they continue to do amazingly well. So there's an element of healing and hope that's over and above the CAT scan and the dog scan. You know, I'm giving you my best stuff, folks, and you're killing me up here. The PET scan, you know what I'm talking about. That all these technologies are great, but they can't provide a biopsy of the soul. Okay? Now, here are 4 keys to the kingdom. This is not brain surgery. This is not rocket science. Number 1, follow a plant-based diet. I know I'm in Texas, so I'm measuring my words very carefully, because Oprah got into big trouble in Odessa. And get onto Google and see what happens when she was rather flippant about the beef industry. So a plant-based diet. Plant-based diet. Prayer, meditation, introspection, crucial to increase killer cells, to increase our sense of well-being. And I've yet to meet anyone among 30,000 cancer patients who did not acknowledge some higher power, however you may define that higher power. Okay? We heard about exercise. Lots of numbers are out there. You heard from Dr. Fricke, roughly 30 to 45 minutes, a couple of days a week, and the importance of exercise, of resistance work. Find that physiatrist who will refer you to a physical therapist about weight gaining, stretch. I need to tell you that I use no performance-enhancing drugs. I've never tested positive for steroids. Folks, please, give me a little love, please. Okay. And what's crucial are friends and relationships. I have read that having a friend is as important as not smoking in our quality of life and lifespan. Now, women outlive men by about 15 years. Why do you think that is? You talk a lot. You have friends. Look at 5 women having dinner. They're yucking it up to have a good time. They're laughing about us. Look at us having dinner. We're whining about our PSA, our stool softeners. I mean, please. But you have a way of looking at life that it sometimes just doesn't work, okay? So, what are the crucial things we gotta do to go the distance? What do we have to do? Number 1, know your diagnosis. Dr. Mesa is a world's expert in myeloproliferative disorders coming from the bone marrow. He explains to the patient what that means. So when that patient walks out of the room, that patient will be able to explain to someone else what it is. So if you don't understand the diagnosis, get on Google, get on a website, so that you can share that information with somebody else. Know what you have. Okay, crucial. What are the options? That young gentleman from Nebraska had options. And the option of treatment was not really good for him. He understood that. So this is an example of informed consent. There are always options regardless of the gravity of the problem. Now, let me tell you a personal story. This is a photograph of my back between the shoulder blades. This is my back. And Dr. Mesa said, please don't take off your shirt. We'll have a riot right here in San Antonio. So let me give you the backdrop on this, okay? What happened? My wife and I were planning a trip to Guatemala, where we have a goddaughter, and my wife noticed a red knot between my shoulder blades. This was tender, this was warm, and it was painful. And most likely, this was a sebaceous cyst, which many of us have. And she said, you better go see that because you don't want to be in Guatemala with a serious problem. So I go to see the skin person who refers me to a derm surgeon. He says, this is no big deal. This is a sebaceous cyst. We can remove this over 15 or 20 minutes. Well, that surgery went on for 1 hour. So I start to think, being a thinking person, this may not have a happy ending. So I go home. He said, I will call you with the outcome, nothing to worry about. So he calls me. He says, I want you to come into the office and we're going to talk about this. Okay. Being a very bright person, I thought this may not be the start of a good day. So he sits down with me, very serious, no smile, no fist bump, and says, you have an undifferentiated pleomorphic sarcoma arising from the skin, arising from the sweat gland. And I start to think, I couldn't remember anything he said. And I've been doing this for 100 years. And he talked about this, and we could do a wide local excision, and we'll take a piece of skin from your buttock and put it on your back, and then we'll remove the lymph nodes under each arm, but I don't know what's going to happen. Okay. If you don't know, what am I going to do? So he spelled out all the options very carefully. I says, you know, this sounds good. You're a good soldier, but I don't think I want to do anything because you have no idea what this thing is going to do. So here we are 18 years later. He's retired. I'm still here with no problem. So the message is, we are not prophets. We can't predict. There's no artificial intelligence to tell us exactly what will happen. So we need to understand what are the risks of doing nothing. Chest x-ray. Black is normal, and this is air, and this big white thing in the middle, patients want to know that's the heart. If that wasn't there, we'd have a serious problem, okay? Okay. Now, this is an example of what we call fluid around the lung, a pleural effusion. This has cancer cells. This is a normal lung. Okay, this is the patient when I first met him 35 years ago. And I said, what were you told by the other institution before you came to Mayo? He says, Doc, I was told to pick out 6 pallbearers and get a good blue suit. Okay, guess what? 30 years later, he's been divorced twice, he's had a bankruptcy, he has the same blue suit, and 5 of the 6 doctors were in a nursing home outside of Minneapolis. So what I'm trying to say, we can't always predict the future, okay? Okay, next, a positive support system. Crucial. If you happen to be married to someone who's negative, give me a call. I'm from New Jersey. We can help fix this very, 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 very quickly, okay? I know someone. We can do this the easy way, or we could do this the hard way. Do I have to draw you a picture, okay? Do you say that in Texas, too? Do I have to draw you a picture? Okay. Now, by all means, if you are comfortable, bring someone with you to the consultation. It's like me going to a lawyer by myself. I'm clueless as to what I'm signing. Now, this is not the kind of couple you want to bring to you to a consultation. Would you want to go on a cruise with people like this? No. You want someone who is listened and respectful. So a situation like this, you have a loving couple, you have a physician who's a human being, he's not on a tablet, has the records, eyeball to eyeball, and between the two, the gentleman and his wife will have a fairly good understanding of what's being promoted. If we go by ourselves, we walk out of the room, we have a migraine, we're not sure what the next steps are. Okay? Now, a quick question. How many of us have spouses or wives or husbands in our families? Okay. And how many of us have pets in our lives? Now, when I ask the first question, the hands go up and nobody smiles. But when I ask the second question, and just ask anybody about their dog or their cat, and you hear all sorts of stories, okay? Now, this is Stevie. Stevie's a golden retriever. Stevie was a thoroughbred, destined for stardom, and she was at a show in Minneapolis, and everything went well. She came home, and then she's bouncing into the piano, bouncing into the wall. She went blind. She went blind overnight from a bizarre fungus infection. But those of you with pets know that connection, that meaning and purpose. And when a pet is disabled, there's more of a commitment to taking care of that pet. And that pet provides meaning and purpose and engagement to keep us going when the days are dark, okay? You know, you look at her, and you just feel good. Blind. Wow. And I've also learned, never look at the vet bills. Just swipe the card. And Dr. Mesa told a story about Squeaky, a hamster. And I've never been incontinent in a public spot, but listening to him talk about Squeaky. Squeaky had more treatment than everybody in this room combined. So how do we tie this all together? Oh, folks, please. I mean, I thought that, I says, Peggy, should I sew the tie? She says, no, they'll take it to the airport and you'll never come back again. So how do we wrap this together? Okay. 3 keys to the kingdom. Keys? Okay. I'm not coming back next year. Okay, number 1, know your diagnosis. It'll have a complex medical term, but look it up so that when you see your hairdresser, your masseuse, your mechanic, you can explain, hey, here's what I have. Expectations. If I have chemotherapy, if I have radiation, if I do this, if I do that, what do you think will happen? Give me some ballpark odds. Give me some percentages. But likewise, tell me what you think will happen if I don't do anything. Shift the odds in our favor with education. And lastly, regardless of the seriousness of the problem, there are always options. There are always alternatives, regardless of how bleak the problem is. So, take a look at this. We're remodeling the kitchen, so we're hoping some brisk sales. By the way, the advice I would give anyone, if you're going to remodel the kitchen, get an MRI of your head, because you will have 6 months of total misery, and you'll be spending more money than you'll ever make in your lifetime. But from a serious standpoint, this is kind of the Rosetta Stone. It's the kind of stuff that we hear from you all so that the next patient can be informed to make the right decisions. So again, here's my email address, creagan.edward@mayo.edu. And the gift you have given us is the gift of your presence. So be safe. God bless all of us. Bye-bye. Thank you.